Hi. So, good afternoon. Uh, Today is June the 12th, 2024, and it is 3:02 p.m. As a quorum of the committee is in attendance, I would like to call to order the meeting of the Central Health Strategic Planning Committee. As a reminder, a committee member may also be participating by video conference, so the staff will be managing video and audio feed of all participants closely to make sure we have a legally compliant meeting at all times. I would like to also announce that in order to make it more accessible to community members, we will hold public communication for the Strategic Planning Committee, the Budget and Finance Committee, the Executive Committee, and the Board of Managers meetings at a time certain of 5:30 p.m. unless a member of the public wishes to comment on a specific item on this agenda. And we will now proceed to the Strategic Planning Committee agenda. So, number one, review and approve the minutes of the May 22nd, 2024 Strategic Planning Committee meeting. Do I hear a approval? Oh, yes, all right, thank you. Yes, so Manager May is approving and Cynthia Valdez is seconding. Number two, receive an update from the Central Health. Oh, I'm sorry. Oh, yeah, vote, okay, I forgot. Everybody vote who agrees? And any disagreement? No, okay. Number two, receive an update from the Central Health President and CEO on his first 100 days. Dr. Pat Lee will be presenting.
Right. Thank you, Chair Brinson and colleagues, for the opportunity to come back and kind of pick up where we left off and move into the second meaty and hopefully exciting part of the 100 Days presentation. So I'm going to invite us to go to this slide in your packet. I don't know if we're presenting a slide deck or not. Do we? Okay. So we want to go to the trust tree slide. And this is where Chair Brinson invited me to sort of begin. This is going kind of back one slide from where we ended, but just to kind of set the stage. So if I'm recalling, last time I had the opportunity to present this slide, I began with a huge thank you to our team, to our staff, to the many people and community members who contributed to the formulation of this version of where we are, and I think how we're trying to move in this space at the current moment. So I just want to say thank you. You make me better. I appreciate all of you. This is all of our shared work. I also had mentioned the invitation to board managers that after you have an opportunity to provide any feedback or make any adjustments, I hope this slide also is useful to you as you are speaking to your colleagues and our constituents and describing the components of where we are and where we're going. We are in the process of building some just a sort of backup to describe what each of these components means, so we should have that also for you to review, but this may hopefully be a way for us to continue to communicate, help people understand why we matter and what we're about. So I'll briefly cover those elements again before we roll into the rest of the presentation. This trunk begins with trust. We know that trust is the first step to health. That message has actually been resonating powerfully with everybody I'm meeting, whether I'm speaking to an elected official or a health system leader, community member, our own team members, our partners, and so on. This is just a community in which I think the message of trust resonates, it makes sense, and it works from many different perspectives. The next step is whole person care. We can think of this as one size fits one. This is not just the medicines and the surgeries, not just the therapy and the substance use disorder care. This is nutrition, housing, transportation, good paying job, the freedom to care for your family, and so on. All the things that really matter. So it's all the things that you need to thrive today And it's also the recognition that this is a journey and not an episode. Your health journey doesn't stop when you leave the threshold of the hospital, when you leave the threshold of the health center. You are living your life, and as we help you live your fullest life and thrive, whole person care is meant to signify that journey as well, that we're alongside you for that journey. One size fits one is hard enough to do, but to do that across all of the people who we have the privilege of serving, about 300,000 people in the current moment, under 200% of the federal poverty limit here in Travis County. That is going to require a level of systems engineering, design thinking, operational excellence, trust, relationships, partnerships in all directions. And that is why we are proceeding as we are to integrate ourselves into this broader community and ensure that we have the connectivity that we need to provide this blanket of care, some of which is within our constitutional mandate, and some of which is not, like housing, but is nevertheless essential for whole person care, so we're going to partner for that effectively. If we do all that well, then we get to the quadruple aim, the outcomes that matter. Aim number one, the kind, compassionate, dignified care we would want for our loved ones, for each other. Aim number two, the health outcomes that matter. Are we diagnosing and curing cancer, stage 1, when it's curable? Are we preventing amputations, the need for dialysis, strokes, heart attacks? Are we getting underneath the root cause of the 10-year early death east of I-35, or the 20-year differences in some of the sharpest disparity areas? Are we doing that? That's vital. That's aim number two. Aim number three is the value of the care. What do we get for what we spend? Are we achieving very high quality outcomes for the investments we make? But as I've learned in my time here, it goes deeper than that, because ultimately we share a common bottom line with the taxpayers of this county. And if a patient enters into the jail because they were picked up for a misdemeanor, because they were unhoused and suffering from serious mental illness and substance use disorder, and once in that spot, they are not able to be competent to stand trial. They are not able to be released. They are not able to get the care that they need in the current state, and that goes on for months or years. I think we can reflect and admit that if we were in that position, it would be very difficult. It would probably break me at a certain period in time, well before years had passed. This is a very difficult place and very expensive, and the public is paying for that. If we can organize ourselves in partnership with others to prevent that problem, to allow patients to flow through this system in a rational way, even if that doesn't accrue back to our financial bottom line, it accrues back to the society bottom line, to our taxpayers' bottom line, and that is the job that we are here to do. If we think about the branches, we begin with financial strength and flexibility. This is the trust of the people of Travis County who voted to create us and endow us with special taxing authority to not have to only do what an insurance company tells us they'll pay for, or only do the things that we can generate a financial return on investment within 365 days. We are not limited by those things. We can actually, and we will actually, and we are actually planning further out and trying to solve the deeper challenges because we can, because we're empowered to, and because of that common bottom line I mentioned earlier. Branch number two is community health DNA. We have learned a lot over these past 19, 20 years as we have built the part of this system that's around partnering and working through about 300 contracts currently and filling in all the many, many gaps and creating a good part of this blanket of care. We actually have that expertise now. A lot of health systems don't. So we bring that strength to the table, and we also do not assume that health is created in the hospital and the purpose of the health system is to feed the hospital and keep the operating rooms busy. For better or worse, that is the sort of unspoken logic in a lot of health systems because that's where the margins are made in the typical way that health systems are paid, but we are not paid that way. That's not our history. It's not our DNA. We're going to build a health system that recognizes that the locus of health is in the community, the patient's context. If that context is vulnerable or fragile, then we will assist in strengthening that context. But we will prevent hospitalizations if at all possible and keep them as short as possible by helping people get out safely as soon as possible. and so on. So Community Health DNA. The third branch is around our family, the Central Health family. Central Health, Community Care, and Sendero Health are one family, one system, one mission. We have the same values, and we are aligned. This synergy, the differences in the ways that we're built and what we can and can't do actually add up to a whole that's greater than sum of the parts. One of the earliest signs of that is the beautiful art mark behind Chair Kitchen, and and increasingly the way that people will relate to us understand that we are one strong family. The next branch is the Health Equity Plan. We are in year 2, as we have been doing throughout, emphasizing, as I will do later on tonight, emphasizing some of the stories of the patients whose lives we are directly touching and transforming and why that matters. We are directly building the center of that health system where there have been persistent gaps for too long, and we weren't able to bridge those gaps through contracts, so we are building directly and we are already delivering those services. It is our North Star. The next branch is around partnerships. As I've said earlier, these are vital. Critical partners include the city and the county, Integral Care, the Dell Med School and UT. The community bullet here includes many actors. Our health system partners, St. David's, Ascension, our community leaders, the educational leaders, the stakeholders and advocates, our patients themselves. This is a whole blanket of care approach. People and culture I've spoken to before. If you want a human being to give kindness and dignity, they have to feel kindness and dignity every day from the organization. For that to happen, that has to be my sort of unrelenting, daily, and continuous message that we lead with love, and we cascade that through the organization. It is the only non-negotiable expectation for all the executive leaders. I've let them know, they've heard me say, and they've beautifully shown up. As I said, I can say these words, but it's your job to make them true, and they are making it true every day. I'm so grateful to my colleagues. It's such an honor to work with them. We have the best team and the best people that I ever had the privilege of working with. And then speak to the heart. We know that human beings, what we feel is where the trust begins, and then we can show up and plan together with our heads, and then we'll get to work together with our hands. So heart, and then head, and then hands, in that order. This has always been the way. This is the way that we will continue to evolve and strengthen our communication to speak to the stories that matter, to communicate with love and purpose. So all of the above is just another way of expressing that we are strongest in one trunk, many branches. And thank you, Dr. Brinson, for reminding me to start on this slide before we go to the next slide. All right, so if we go to the next slide, early wins for trust. Just to remind us, the provenance of this 6 wins are probably the first conversation that Chair Kitchen and I had, in which we were asking ourselves, well, what are the early wins? We were both starting our tenures, and we've been having a continuous conversation over the months since then. There were probably 20 really good ideas that we narrowed down to these 6, with the notion that if everything is a priority, then actually nothing is really a priority. And part of our job here on this table is to do the strategy work of asking, well, what are we actually not going to do, so that the things that we are going to do get the focus they need and we can really deliver. So that's the intent here. What you'll see in the slides that follow, as I invite my colleagues to come up and present their components, are the FY24 goals. I recognize FY24 is coming up, on us quickly, so these are going to be initial goals that reflect work that has already been happening to some degree, because we're already focused on some of these issues, a lot of these issues, maybe all of these issues, and where we hope to be by the end of the fiscal year. For the first 2 goals here, specialty care and respite care, these are part of the healthcare equity plan. We have a 7-year plan around that, so we'll show a preview of the FY25 goals. Those aren't final yet, but just to give you a sense of the inflection point and what that looks like as we go from laying down a thin layer of topsoil across many different specialties, for example, and then we begin to scale up in the following year, maybe 8 to 10x. So you'll see the preview there. The other goals, we don't know yet what FY25 looks like, but more to come as we circle back. So these are FY24 goals. You'll see for each of them that we have structured them to describe what is the purpose of this goal, what is the value if we accomplish the goal, and then what is the minimum threshold of success what is the target that we would love to hit, and what is the stretch if we happen to knock it over the fence. And so that's the basic structure you'll see in the three for each goal that follows. I will share that the goal for today is really to give this high-level overview for the board. We're going to cover a lot of ground. These are only 6 goals, but as you hopefully will appreciate, they cover a great deal of what is most important to us. And so we won't go too deep into the operational specifics for each one. In fact, in some cases, we don't have all the operational specifics answered. I'm really helping our team have the permission to understand first, what do we need to accomplish? Second, where are we now? And third, how are we going to close the distance? And so those are the sequence of how we lead. So we don't have, in every case, all the operational details anyways today. We want to make sure we're aligned on goal together with all of you. And so that's really the goal for today. And with that, let me pause and check if there's any other questions for me before I yield a hot seat to my colleagues to walk through these 6 early wins for trust. All right, thank you so much. John and Alan, y'all are up.
All right, good afternoon. I'd just like to pause for just a moment and recognize Pat's first 100 days. I think in many ways it seems like a lot more than 100 days, but I think that's a testament to Dr. Lee's engagement. I can't imagine anybody coming into this role in this environment more enthusiastically, passionately, thoughtfully, really serving as our leader, being both supportive of us as a staff and also gently pushing us forward and challenging our thinking and really helping pave the way going forward. So thank you, Pat, and glad to have you. Our first focus area or early win that we'd like to speak to today is specialty care, which should really serve as no surprise for you all. As Pat mentioned, we've had gaps in specialty care services for some time, and one of the ways that we can build trust with our community, with our patients, is by doing what we said we were going to do, which is really creating sustainable solutions, dedicated capacity, and fixing some of the gaps in specialty care that our patients have experienced for years. We still have a long way to go. This year has been around getting a foot in the door, getting started. And I think you'll see we've actually provided a preview of what this looks like going into FY25 as well. But this is about creating equitable access for our patients so that our patients have the same, if not better, access to services, care teams, treatments that anybody else in this community has. And I think we've made meaningful progress this year, as you all have seen in our stoplight dashboard report for the budget resolution. But again, we're really just getting started. So what you'll see here are some minimum thresholds in terms of patient visits. Before we can really change clinical outcomes and health outcomes for our patients, we've really got to create that access. And these modest numbers are also very critical numbers for the individuals that we're able to serve in the environment today. And then you'll see as we move forward that this grows significantly going into FY25. Next slide. So going into fiscal year 25, we're looking at approximately 8 to 10 times the increase in volumes in terms of serving our patients. This is reflective of opening our Rosewood Zaragoza Multi-Specialty Center. This is scaling and stabilizing the service lines that we've presented on for our work this year, so scaling those out into FY25, and then also starting to add some additional service lines that we'll speak to more this year. These are fairly aggressive goals, or minimum threshold that we'd like to that we would like to achieve by the end of next year is 20,000 annual patient encounters. But really, we're stretching for that top line goal of 40,000. And think that we're in a really good position to be able to execute on that. So again, this is really just a preview. The last slide was where we hope to end in FY24, and this is a preview of where we would like to take this going forward into 25. And then the evolution of this gets beyond patient encounters to timely access to treatment, to different types of process and quality outcomes. Next slide.
Good afternoon, managers. Actually, can we go one more slide, please? There you go. Nope.
Too far.
Yep, one back. There you go. Our second early win and opportunity to earn trust with the communities we serve, specifically the unhoused, is to provide specific opportunity for individuals to rest, recover, and heal in a safe environment, while also providing them access to clinical care and support services. As you all are keenly aware, we've been working on respite for a little over a year and a half. We started with 5 beds within one contracted environment, and a couple of months ago transitioned to up to 25 beds in 3 different contracted environments. So when looking at goals for this year, we've kind of had changing variables. So I think when we look at 25, I can give much more, or I can give an explanation that's much more objective in nature as far as how we came up with these goals. This year is really about getting respite up and running in environments that are not our own, as well as providing supportive services to those individuals that then sit within those environments. So we also wanted to look at how do we utilize the available beds efficiently. And so anytime we have a bed, we're looking at a longitudinal approach to what were the availability, how many days did we have available, and how many beds did we have available. And if we actually multiply those two, those are bed days. And I think in FY25, it'll be much easier to understand. I'll explain that then. For this year, we kind of cheated. We know where we are now. We're 3/4 the way through the fiscal year, but we did want to push ourselves to see how many patients we could get within kind of these respite environments and then connect them to services. So we are very close to that target environment, and we're going to have to push ourselves to really hit kind of the 3,600 patient bed days. At the same time, we're very proud to announce that our bridge team was up and running as of last week. Now this is, and I'll go into a much more elaborate explanation, this is the in-clinic presence of our bridge team and the first phase of that in-clinic presence. And again, I'll explain that a little bit more later. As far as getting a mobile team up and running, our teams are planning. We don't have a vehicle. We don't have the operating policies and procedures. And so that is scheduled to get up and running late September, early October. Therefore, it really is, it does serve as a stretch goal. And again, this year is focused on contracted respite environments. And then next year, if we can go to the next slide, please. Next year is focused on owned and operated respite opportunities for our patients. So what we're looking at is the build out of the CEC. We think it's going to take about a year to plan and build that out. And so we're really looking at the last quarter of FY25 to have owned and operated opportunities for respite. And that's where the bed days come into play. If we have, let's say, so our threshold goal is getting it up and running, right? Our target goal is, let's say we get 20 beds up and running for 90 days. That's 1,800 bed days. If we hit 80% of capacity, that is where you get to the 1,440, right? So trying to maximize the opportunity when that opportunity is up and running. At the same time, we don't want to give up our contracted partners and the environments that may be somewhat unique for our patients that may thrive in that contracted environment. However, we know that we're not going to be that efficient, so filling both contracted and owned and operated bed days at 100% is probably not realistic. So we slightly back down from our max days that we hit. You know, our stretch goal this year, to consider that for next year. So our stretch goals for next year are owned and operated 30 beds for that last quarter for 90 days at kind of at 80%, 80% capacity, and then, you know, the 3,000 patient bed days from the contracted environments. And I think if you look at it as far as additive bed days, it's anywhere between 1,600 and 2,000 additional bed days over what our threshold or our stretch goal is this year. Next slide. Yep.
Please.
A very quick question, just so I understand. So on the 2025, on the 2025, okay, sorry. On the 2025, the contracted, that, how many beds does that represent?
So the,
Not the operational ones, the contracted ones.
so it'll still be 25.
It'll be
contracted
25,
bed.
okay. Okay, so the stretch is 25 contracted and 30 operational. Okay, thank you.
Manager Valdez.
This is just a real quick follow-up, Alan and John. The staff, you said we have contractors that we're housing our patients in right now?
Contracted
Until
environments.
we're up and running? Is it their staff that's providing the services?
It
Okay.
is, it
And
is.
when we're up, it's gonna be our staff that's providing the services?
And Manager Valdez, right now, those beds are largely non-clinical. Some of those organizations do provide some case management supports, but there really isn't that medical services overlay. So that's what the bridge team that Dr. Shawshire mentioned, we're providing some care for those individuals in our clinical environment. But that's the benefit of moving into an owned and operated environment, is we can coordinate those services a lot more closely.
Just follow up to that, on our contractors right now, are they in the SNFs?
So we do use skilled nursing environments, but we also have shelter-based environments. We have boarding homes that we're working with.
Okay.
So it's a variety of settings based on the individual needs.
Okay, the only reason I'm asking is because, you know, when we get into the SNF environment, we have such lousy SNFs, and then we have such great SNFs. So if we're looking, we need to be looking at the quality of care complaints that have been filed, because I myself have filed some, but anyway.
I think the advantage we have there is we use multiple SNFs, but within 3 SNFs, we actually have up to 30 patients that we directly manage. So it's our providers and our care teams that oversee the care of our patients. So the quality of care is much better there.
Thank you.
I'm sorry, I thought we were
Yes.
gonna wait for questions to the end. So if I have a question for Pat, can I ask, will he be able to come back up at the end? Answer
Yes,
this?
yes,
Okay,
yes.
thank you.
Not go anywhere.
All right, good afternoon, Jeannie Verdon, Enterprise Chief Human Resources Officer. Good to be here, and I'm here today to talk about our early win number 3, which is revolving around our people and our culture. All of the great work that we have done to date, that we're doing today, and that we're planning on doing moving forward really rests with our team members. Without them, we could not do the work that we need to do. And so within that, we realize that cultivating a workplace that enhances job satisfaction for everyone is very critical to our success. We have a very diverse workforce, and each one of the team members want and need something different to achieve their own career fulfillment and satisfaction. And we realize it's vital that we continue to provide a space where all team members feel valued, supported, which in turn drives team member morale, productivity, and retention. This year, we did a survey, and our job satisfaction score was at 82%, which is very, very high. We would like to use that as our threshold goal, but really our intent is to invest the time and the effort to not only maintain, but more specifically improve our workplace and our workplace culture, especially during this time of rapid change and growth. So our stretch goal that we would like to achieve is 84% job satisfaction or higher. Each percentage point that we would increase indicates that the enhanced experiences and perceptions among our workforce just demonstrates our ongoing commitment to providing a place where we are committed to their well-being, as well as creating an adaptable, supportive work environment for everyone that works for us. Thank you.
Yes, Manager Valdez.
I thought about asking, but I think I do agree we should wait till the end. But I'll come back to you, Jean.
Okay. Okay. I'm not sure who I'm handing it off now to. But you too, come on up. Come on.
Only two chairs.
No, there's a third chair now. Look at this. This is Dr. Schultz's chair. This is a system goal, and I think you all know that we're really committed to working with Sendero and community care, where we can improve the patient experience and also create financial sustainability and overall organizational sustainability, really provide a high-value system in Travis County. This has a number of deliverables. I think some of them you know have already been implemented. I think the one that's most obvious is right behind Manager Chair Kitchen there, and the unified branding strategy. And I think this actually demonstrates the trust that our component entities have in the central health system vision. I think we all have a role to play. This is really creating a strong foundation to support the branches of the tree. We are trying to solve problems, and I think one of the things that John will talk a little bit more about is a shared eligibility goal to build trust, but really to improve that patient experience, the people who are enrolling at sites, but also to create financial sustainability for community care to make sure that the people who are eligible for MAP and MAP Basic, for example, are actually enrolled in that program and not letting the sliding fee scale try to take care of them. I think that there's a lot of work to be done, but we have, I think, some initial success with Sendero in creating, developing the TPA services that support both Central Health and Sendero. So another sign that I think we are moving in the right direction, all rowing in the same direction. One of the goals is actually a more clinical focused goal, and that's on colorectal cancer, and Dr. Shawshall will speak to that. And I think there is a lot of work, and I think the work that is really important is the establishing trust piece. And I think we've made we have been meeting together as working groups with the three entities to really establish that trust. And so what you see here are so many details. You might go, well, why are there so many steps to this? And I think really creating that shared platform of trust was important, and I think we have reached that, and now really kind of talking about more of the operational pieces, and have developed kind of a vision of these goals that I will hand over to John here.
Thank you.
Next slide, please.
Next slide. So as Stephanie mentioned, we have been working closely with our colleagues at Community Care and Sendero over the past couple of months, really working first to identify a shared operational and clinical goal, which, as you can see, we landed on an eligibility-focused and enrollment-focused goal for the operational and colorectal cancer screening for the clinical. For the eligibility goal, it's pretty simple. We want to improve the number of individuals served in the community care environment who have active coverage of whatever kind they're eligible for. So that could be enrollment in MAP and MAP Basic, that could be enrollment in Medicaid, that could be enrollment in an ACA plan with premium assistance, But that's really what we're focused on is improving the rate of patients who are actively enrolled or decreasing the number of patients who are presenting as self-pay or completely uncovered uninsured. The value of this is really substantial. If patients are not enrolled in a coverage program, it severely limits their access to services outside of the community care environment. Stephanie mentioned also the financial sustainability aspect of this. That's certainly important. But if you're not enrolled in some form of coverage, your access to care really ends once you leave community care's four walls. So we really want to make sure that our patients throughout the community have access to the full range of services that they need to treat their underlying conditions. In terms of our initial metric, we really focused on two. The first is reducing that percentage of uninsured patients at community care, or the number. Just to give you a point of reference, that's approximately 11 or 12,000 individuals annually, or about 10% of the patients served at community care. Part of our work over the next few weeks will really be to hone in on that measure specification and setting the baselines and the targets, but we're looking to meaningfully move the needle on that particular measure. The second metric is related to our MAP Basic program enrollees. When we created MAP Basic, we intentionally allowed people to be enrolled in MAP Basic who may be eligible for other coverage but are not actively enrolled. That way we have a proactive relationship with those individuals and we can help them navigate the enrollment process. So we have about 3,400 individuals in MAP Basic today who are potentially eligible for Medicaid. I say potentially because we really don't know until we engage with them and help navigate that eligibility process. But we want to make sure that we're getting patients into the right program. So that MAP Basic coverage is intended to be temporary, more of a gap coverage while we help navigate people into Medicaid. And then, we have two additional future iterations of this metric. Right now, we're really focused on the community care environment and on Travis County residents. Community care also has uninsured individuals from outside of Travis County, and that could be part of the way that this metric evolves, as well as taking more of a top-down instead of a bottom-up approach, or more of a population-based approach where we set a goal around the potentially eligible population in Travis County and then work to close the gap on individuals who are eligible for our programs but not yet enrolled. So just to give you a sense of where we might take this in future years.
And John, I might add that community care is really looking at, they're developing some patient focus groups and trying to figure out directly from the people who are not re-enrolling why they are not re-enrolling in coverage.
And this will take the form of multiple interventions, and that's part of our deliverable as well over the remainder of this year, is to develop that action plan for how we're going to move both of these metrics.
Next slide.
Thank you. When speaking to our partners, we wanted to consider jointly how can we have the greatest effect on the communities, for whom we care, and secondary prevention really rose to the top. So early detection or prevention of disease really is life-changing for our jointly cared for communities, and that coupled to when you look at our screening rates specifically after COVID, COVID prevented folks from coming into clinic and getting the screening that they really needed to receive. And so rates really across the world, dipped, and that we were not spared that. So screening rates for colorectal cancer across our system are mid to high 30s, which if you look at healthy people you look at healthy people now, really U.S. screening rates are close to 60%. So we have significant opportunity there. And, in speaking with our partners, we want it to be as inclusive as possible for the folks who sit within the county. And so looking at a denominator, well, looking at individuals who are 45 to 75, who sit within the county, who are MAP or MAP Basic, who are Sendero, CHAP, or CHAP expansion patients, really serve as our denominator. And then for the first step, we're just looking at any kind of screening, right? And our goal is looking at our baseline and raising that 5 percentage points above where we currently sit by the end of this year. Now, as we progress jointly and become more sophisticated in our approach, we do want to diversify by race and ethnicity because there are specific disparities that sit, within, and then we can start catering to the screening based on kind of those disparities. Ultimately, it's not only the screening, but it's the definitive endpoint care that we'd like to get to. And so it's the diagnostic or potentially therapeutic care that we'd like to ensure that folks receive within a certain time period. And that may actually be our third iteration of this. Again, we're building across our system, and so increasing access for endoscopies, colonoscopies, and so as our sophistication and our work together matures, so our care will improve as a system. And so this is a really meaningful joint initiative among partners.
Thank you. And thank you.
Thank you. Monica Crowley, Chief Strategy Officer. The early win that I'm discussing is work related to addressing inmate health and jail diversion, focused on improving care for one of the most at-risk and vulnerable populations that is served by Central Health and by our partners. This work has involved and continues to involve intense collaboration and ongoing alignment so that we can use all of the resources that Central Health and our partners have to address gaps in care for this population and to focus on improvement in outcomes that none of us could achieve working alone. It has been a true honor to work much more closely with our partners at Integral Care who are here. They've come early to participate in all of our meetings today, and then also to get to know people at the Sheriff's Department and to collaborate with truly mission-aligned partners that are very interested in serving this very vulnerable population much better. The deliverables involve not only expanding access to specialty care for people who are inmates in jail, but also involve diverting patients to more effective care settings and also providing more effective care transitions upon reentry so that we could improve equity for justice-involved patients by improving their outcomes and hopefully saving lives. Some of the initial deliverables, and these are goals that there are 8 goals total, and our stretch goal is before the end of fiscal year 2024, so within the next 3 months to achieve 6 of these 8 goals. One is to implement at least one specialty line at Central Health for inmates. We have begun offering podiatry at our East Clinic for inmates in the Travis County Jail. We also are aiming to implement additional specialty lines, including cardiology, before the end of this fiscal year. We also are actively working right now to provide an enhanced access to substance use disorder medication for inmates and not have inmates that are staying in the jail tapered off substance abuse disorder medications that they need. We are continuing to work on ways to improve and enhance MAP enrollment for people when they're in the Travis County Jail and to ensure that they leave with a map in place. We also are collaborating with community care in the jail to enhance access to HIV and hepatitis C treatments for eligible inmates. We also have started already, and you'll hear a little bit more about this later in your integral care update. We have already begun phase 1 of the diversion services pilot by expanding psychiatric emergency services in partnership with integral care. We are continuing to work on participating in the diversion pilot steering committee and work groups. We have a meeting scheduled next week with the city and the county and integral care to continue planning for diversion services, pilot services going into fiscal year 2025. And then we also are actively, we had a meeting earlier this afternoon, planning with integral care on the mental health continuum of care and also including diversion services. This will be one of the emerging priorities that is being proposed in the next presentation for fiscal year 2025 proposed strategic priorities.
Yes, please.
Thank you, Monica. I'm really delighted to see the progress that we have made. Thank you for that. I have a quick question. In terms of the inmates, are those Travis County inmates or all inmates, whoever ends up in Travis County Jail? Just for clarity.
So they're Travis County inmates, and we also are offering services. However, there will be a relationship developed with the Sheriff's Department for them to compensate us for services that we would provide in our specialty care setting for people who are not Travis County residents.
Okay. It's unfortunate that we cannot provide care beyond that. Maybe some way that we can collaborate with our partners. I don't know, maybe down the road. I just hate for them to not have access to care once they're out of jail. Again, thank you for that clarification.
Thank you.
Okay, managers. So I'm here I'm going to talk a little bit about our early win for trust number 6. And Ted and Jeff also contributed to developing this goal, but really what this is, it's about improving community and board alignment and support for our fiscal year 2025 strategic priorities and budget development. And this does include with our elected officials as well. This goal is important because it bolsters relationships in the community, it builds trust, it allows us to better communicate and encourage us to better communicate and engage with our community and build support for our work. And what you will see here are 7 deliverables. And these are really their opportunities for two-way listening and understanding that we believe raises the level of trust with Central Health for the work we do, and also helps us build a better and stronger response to community needs. I'll just mention a few key deliverables. You can see them there, but in terms of the board, and some of you have already been included in some one-on-one briefings with Travis County commissioners before our last work session. We have a deliverable to include board managers in at least 2 of those 4 rounds of briefings that we do with county commissioners leading up to our budget vote. We are working to engage with elected officials on a monthly basis through communication by email, but also in-person meetings and presentations. We have in the works for work sessions and presentations, we've already completed one of those, so we're 25% to that deliverable. And we're working on the next, which is scheduled for July 25th. And then Ted and his team are working to produce 3 community conversations. We'll also be working with Ted and his team. And we've done one of those already, and we have another, I think, scheduled for July 2nd, I think. We'll also work with Ted's team on a public hearing. And our target is to achieve 5 of these 7 deliverables. I'd love to, achieve our stretch goal of achieving 6 of those 7. I think we're on our way to our stretch.
And it's July 1st, sorry.
July 1st, okay. And that's the next community conversation. Thank you.
So we'd love to open up and really welcome and get your thoughts. I'll stay in this spot and leave the hot seat open for colleagues as they get called to respond to questions, but we'd love to hear your thoughts and your questions and recommendations.
Well, we'll start with Manager Valadez.
With respect to the, let me go back. I guess it was Alan and John, when y'all, in your presentation, are we looking at the cost breakdown for the provision of specialty services? And are we gonna be able to compare that with other hospitals or other entities that are providing specialty services, so we can see, whether or not there's something that needs to be, I guess, aligned or differentiated in the cost? You know?
Yes, we will absolutely be monitoring costs across our specialty care services.
Will we be able to see that?
Yes, and that's part of the budget presentation coming up as well. You'll see the dollars that are planned to be spent in that space. We're still developing some of the operational and financial metrics around all of our practice areas, and we can speak to this more in the budget presentation, but we will have a lot more upfront costs as we're building infrastructure, and you'll see that some of those infrastructure type functions and positions really start to level out over time, but support a larger clinical practice as that continues to scale. So we'll have a couple of graphs in the budget presentation that speak to that.
That would be great. One of the things that I remember is when we would see community care breakdown in the cost of care, and I don't think we've seen that in a long time. Because then you could look at how it's gonna cost, community care like $3,000 per patient or whatever, and regardless of whatever it was, that's a hypothetical, but I would like to see that.
Yes, ma'am.
With respect to the, talk about I guess on this sheet, about the joint system eligibility goal, and we're talking about the uninsured patients in community care, approximately 12,000. What about our uninsured patients in uninsured Travis County residents that are not patients? Because to me, that is an important number, and we need to be cognizant of that to lower that number.
Yes. And I
Because
think
I don't see it anywhere here.
that's where we were looking at that second potential future metric of improving
Right.
enrollment in uninsured Travis County residents less than 200%. I think we're really looking at the current joint eligibility goal as being something that is, it's very specific, it's measurable, and it's a good place for us to get started. We do monitor that metric that you're speaking to, Manager Valdez, in our demographic report, and I think that's why we wanted to recognize it on here, is we don't want to lose sight of that population. But it's also a much more difficult number to estimate based on the census data and how all that's collected.
No, we've seen anywhere from 175 to 200,000 in Travis County, uninsured. And we know a huge number of that, of course, are minorities. So I think that is a number we need to at least cite somewhere.
Understood.
Okay, and then last question, healthy. When you talked about Travis County healthy rates, I think you talked about the national rates, about 60%?
Healthy people, 20, 30, and
Do we happen to have that number for Travis County?
I think
Or is that anything that you can actually break down or see?
I think if we're looking at federally qualified health centers, we can look at the UDS data, which is how FQHCs compare themselves and what they have to report annually. So yes, we have that information.
I think the reason I'm saying that is because it's always a good thing to the public and to our electeds to cite Travis County, and this is the impact we have on Travis County with our tax dollars and with respect to the services that we're providing.
I think we can look into that. I'm not sure if an equivalent Travis County number exists, so we can go back and research that.
Thank you.
Thank you. And any other questions or comments? Oh,
I'm sorry, I forgot one for Jeannie, but I'll deal with that offline. Thank you.
okay, yes, we'll just go around in order.
Well, thank you all. Stay to my question. As you know, I'm happy to see that you're expanding your colorectal cancer screening, which is wonderful. What about the other cancers? What do you have down the pipeline? So I'll just be curious to know. Thank you.
I think the screening for all the other cancers continues, and the efforts, there were challenges when we transitioned to Epic, right? There's something within Epic that's called care gaps, and it's actually something you can look at with an electronic health record that shows where the opportunities are per patient. And that all had to be trued up, and I think, we lost a step there because the data wasn't valid. So now that the data has been validated kind of across the system, screening for individuals for all age-appropriate preventative cancers, I think is increasing almost at a logarithmic, scale, because the infrastructure within the clinic system is there. So this is our first initiative that we're doing jointly, where we're saying we have a joint target, we have a joint initiative, we'll have joint education, joint marketing, and I think it's meant as a first. And then we can pick the next one and the next one and the next one. But the individual advocacy for patients and screenings still is underway.
Thank you. Do you think the success of this colorectal cancer screening goes back to the CPRIT grant that the Dell Medical School received and the Carry On, Dr. Pignoni and his team? So I just wondered if that had any kind of positive implication to what we're doing.
Absolutely. I'm going to brag a little bit about CUC. I think CUC actually so Central Health, Dell, and CUC all joined in partnership for the CPRIT grants. And I think the colorectal screening, the FIT tests were one aspect of those grants. There was tobacco screening and some addiction disorder environments where there's partnership as well. And there was a jump, definitely, when FIT tests were mailed out to patients, in that partnership. CUC also actually put a lot of effort, energy, and creativity to moving colorectal screening forward, and so actually jumped in addition to CPRIT. So it was CPRIT and then when COVID hit, a lot of kind of that methodology fell away, and that's when there was kind of a little bit of a backstep.
May I build on this response just for a moment? These two goals nest underneath an early win for trust around a unified safety net health system meant to signify that Central Health, Community Care, and Sendero are increasingly working as one integrated, aligned system. So not only are the goals important in of themselves, but to my knowledge, this may be amongst the first, if not the first time, that there's been the same numerator, the same denominator, and the same target identified as a strategic priority for all three organizations, the first two shared goals. And so at some level, the most important outcome is that we go together. And we set the goal together. The executive teams work side by side to develop the target specifically together. And then now they're working side by side to develop the understanding of what it will take to close the gap to target and present a plan together, and we will go together. So that is the underlying additional benefit of achieving these goals that in and themselves are worthwhile. But if we go side by side together, what else do we get to build on together beyond that? So I just want to underline that broader intention to continue to align the forces even more closely here.
And I believe Manager Valdez wanted to ask about pediatric cancer.
Yes, and when we do the breakdown on demographics for who we're serving with our patients and the descriptions, you know, zip code, ethnicity, et cetera, I'd like for us to also be cognizant of their age, so that we can try and get a handle on how many children are making it to adulthood, and directly as a result of services that they're getting from us, hopefully, or in support of. Especially, and I think I'm saying that in anticipation of something happening with MD Anderson. So, in case nobody's saying it, I'm saying it, just in case. Bye.
Manager Jones?
Thanks very much. This is very helpful and informative, Pat, in terms of understanding the strategy. I just have more of a sort of an epidemiological question. When we look at the data that we're collecting or will be collecting in these various categories, is there any way to ascertain how many of them are within our population that are in what I call in and out of the system, yes, over a period of time? It's my hypothesis that we see people who will come in because of their economic situation. We're treating them, and then they leave out. And then there's the other group that I think Manager Valadez was talking about, who are not at all being seen at all. They're out there, but are not. So that's one question. I'm not sure we're going to be able to get an answer to, if we'll be able to monitor that on a systems basis. The second question is more of a demographic, public health type of question. Are we able to track morbidity or chronic disease rates based upon race and ethnicity on a more frequent basis, so that we'll have a picture of what impact we are having, if any, on those particular populations? One of the things we did at Public Health was that, and we looked at all the population and not just our population, is to see over time what rates were occurring with regards to the various racial and ethnic groups. And what we saw, like the population, is over time from, I think it was 2005, I forgot an exact year, up until 2017, I know when I left, we saw a gradual improvement, particularly in populations' health outcomes, or should I say it another way, lack of mortality in those populations. Now, many factors go to play into those, but it'd be helpful to see what impact, if any, we're having in terms of what we're seeing of the populations that we're serving. So that was a long way of saying, is there a way we can get the data and report it as an effort to support the efforts that we're trying to do with our commissioners?
Can I answer the easier question and leave you the harder question? To your second question, I think absolutely. And I think we almost have to do that based on disease. And so we are looking more and more at that, and we'll be tracking that, and actually need to start breaking that down by race and ethnicity, because we may need to cultivate specific treatments and specific care methodologies based on that. So, as we become more sophisticated and build out, absolutely. And then I'm going to leave the hard question to John.
And we'll add like the age and language as well, we heard you. Sure, there may be other demographics that are very important, so breaking out by key demographics.
I'd like to go back and think through your question a little bit, and not give you an off-the-cuff answer, but just a few thoughts initially. We do have patients that it's difficult to track when they leave our population. If they leave our enrollment or they leave our enterprise clinical environment, we can lose track of them entirely until they come back. I don't think we've had any information up to this point on where those individuals go before they come back, if they just lose coverage altogether and don't access care in the system, or we know that we lose most of our pregnant women to Medicaid over the course of their pregnancy, and then those women come back to our population. But we don't know other circumstances that may take place there. Mortality data is particularly difficult for us. We don't have ready access to comprehensive mortality data right now. That's something our team continues to pursue. It's very important for us to be able to demonstrate the effect of the work that we do and that the health system does, and hopefully we can make a difference over time. I think that the reporting question and frequency, I'd like to go back and talk to the team about. Right now, we capture some of those elements in the annual reporting, and then the demographic reporting that we do is every 2 years. If the board wants to see that more often than every 2 years, or some components of it, I think we'll just have to go back and see what's doable. The last thing I would add is, as we enter into direct practice, we have a different relationship with patients, and we have a different level of data, a much more robust level of data, and opportunities to engage with patients than when we were doing that through contracted relationships. So I think there are opportunities for improvement there as well.
I just want to say, in closing, I think that I want to say thank you to Dr. Lee and to your whole team. What I appreciate about what you presented to us is that it's a very structured approach for some very thoughtful early wins, and it's complete with targets and stretch goals. So I see it as something that we can really, that has structure to it, and something we can sink our teeth into. So I very much appreciate that approach. And I think Dr. Brinson mentioned this too. I do love the tree. I think that is very cool. Thank you.
Well, and I just want to say, Dr. Lee, for your first 100 days, it has felt very organized, very on target, and I think very much what we in the community need. But also I feel that your team had started this process, before you even got here, and they were already on the right, Mr. Morgan and Dr. Shaughnessy, on the right track. But this bringing together of the whole structure as cohesively as this has been done has been very much appreciated and admired. So thank you for the first great 100 days. Yes.
Dr. Brinson?
Yes.
I'm sorry I didn't fight for attention enough earlier, and so I hate to ruin the closings, but I echo them. And with that said, I just wanted to also echo what Manager Valadez said about potentially. Now, I love this product, and I really love the approach as has been stated. This is exactly, I think, what a good governance board needs on manifold levels. And with that said, if there is a way to incorporate expense metrics in as another axis or a dimension of some of these, particularly around specialty care, so if we can say, for us to accomplish this, that means we've expended Y. And for us to be able to calibrate that somehow, so if we were, say, to be looking at a chart, maybe the size of the point would be larger or smaller based on variance or what have you, but some way for us to characterize the dimensionality of the expense component I do think that's really material, and that's helpful to me. I don't want to pile on, because having a simple, clean product like this that allows us to say, we'll meet you on that hill over there, is also of a lot of benefit to us. So it's just fun for me to throw stuff at y'all and say, hey, can you figure it out and make it clean? There's that, and also, Dr. Lee, when we were first introduced to you, you said something, and it was, it was in passing, and I think that there was some there, and you were mentioning, just off the cuff, what if we were to reduce healthcare disparities by 50% in Travis County over the next 10 years. And everyone kind of looked at you and you're like, yeah, really? And so I don't know where and how a stretch like that fits in any of these constellations, but I just want to say that I remember that. Thanks.
7 years.
Chair. 7 years.
Thank you for your kind words and challenge accepted. I haven't forgotten that aspirational goal to reduce the health disparities by 50%. Our first step is to carefully define exactly which health disparities we're going after. We can't boil half the ocean. That's not the goal. But which health disparities? And I think we're beginning to work our way toward that. So we'll take that as a challenge to really define that journey to that hill to climb. We don't have that yet, but I think we're on our way. Thank you.
All right, so we will move forward. Next, we will receive an update on the central health dashboards associated with service level reporting for fiscal year 2024. Or did I skip one? What? Oh, I'm sorry. Number 3, yes, okay. So this we're going to talk for a minute. 3, yeah. Present and discuss Central Health fiscal year 25 proposed strategic priorities derived from the Healthcare Equity Plan, emerging priorities, including recommendations made by the board. What I'd like to say to the board about this is, though we are going to discuss some of the board recommendations, we're not going to go into detail. We're not going to go into great discussion with the individual board members about this, because we plan on having a special called advisory board meeting, probably on July 17th, to actually be able to focus on those issues very distinctly. So we don't want to bring that up in great detail tonight. Mainly this is just sort of a cohesive educational presentation. So, thank you. And it will be, as you can see, John Morgan and Dr. Shaughnessy again, and Monica Crowley presenting.
And I may go ahead and get us started here. I'll tee this up with, I think, a note of admiration and respect for the team at the table and the team that stands behind the folks at the table. We've been firing on a lot of cylinders all at once. And the team has continued to produce thoughtful and I think well-founded work with grace, though not without a great deal of effort. And so I just want to acknowledge how much work has gone into hopefully what you all will see in the subsequent presentations as we roll through from strategy into finance. So just to orient us, next slide, this is one of, in case you noticed it, this was one of the early win 6 deliverables. Next slide, please, is to actually have this timeline. So one box has been checked, if you will. And you can see a little bit of, I think this is like the London Tube sign, right? We are here. So we are here in June, just to kind of orient us. We continue to tweak and improve this graphic. And you can see that in June, the work is to complete the budget alignment of strategic priorities. It really overlap with public involvement and the work sessions, and so we are on target for where we want to be at this point in the year. Next slide, please. With kudos to Monica's team, we are representing a great deal of detail in the Healthcare Equity Strategic Plan in this graphic, and you'll see this graphic come back, but this graphic is meant to represent the full strategic imperatives of access capacity, care coordination, member enrollment engagement, and system of care infrastructure under which the Healthcare Equity Plan initiatives are organized. And so you'll see that organization carried through as we first discuss what we want to accomplish, and then the Budget Finance Committee come back and put numbers around those goals and roll it all up into a projection. So next slide, please. And then this graphic is also meant to serve as a kind of, here's where we are in this conversation. So on the left there, you've got the tree that I also really like, Dr. Brinson and Chair Kitchen. So thanks, I'm glad we share that. So that's meant to stand in for the broader notion of what we're about, as well as some of these early wins that we've covered. You see that graphic on the top meant to represent in the middle the whole healthcare equity strategic plan. This is the foundation of what we need to accomplish, and you'll hear a lot around that. You see below that these driving forces toward change, which is meant to represent the emerging priorities that we have chosen to lift up and gain focus around, some of which will move forward into strategic planning, and some of which may not move forward fully this year, but we know about them, and the exercise has nevertheless increased our visibility. So these two sets of priorities will then roll over to the right, and that, I think this is probably which I don't know what kind of budget statement this is, but this is a budget statement that's meant to represent exactly how these priorities then iterate into numbers. So we are for this conversation in the middle row here, we're going to talk about the Health Equity Strategic Plan initiatives, and then name the driving forces and emerging priority goals that emerge from that part of our work. Next slide, please. And so with this, I'll hand over to Monica.
Thank you, Pat, and thank you, Dr. Brunson and the managers. So now we are going to review the proposed fiscal year 2025 strategic priorities that implement the healthcare equity plan and also that reflect staff proposed work to address the emerging priorities that Pat just mentioned. Then we'll provide an update on the emerging priorities proposed by members of the Board of Managers. And I'd like to start off by thanking you all for joining us in this collaborative process and making proposals. That level of engagement is really important, and we really appreciate it. The next slides, and Manager Motwani, thank you for your comment on the last one. I almost had a Hermione Granger moment where I had to keep my hand down and save it for right now. But the next slide should look familiar because the way that the initiatives are organized is not just around the strategic imperatives, but around the community needs that were identified in the healthcare equity implementation plan. If you remember, there were a couple of slides worth of charts in which financial budgets and estimates over the 7 years were attached to each of those community needs. When we came back a few months ago and presented on kind of where we are in the healthcare equity plan, we organized it in this manner with the community needs, the 24 work that was underway, and also kind of the spend that was underway and where we stood with the spend. All of the different presentations today, as Pat just described, build on each other. By the time we get to the budget presentation, there will be dollars attached to slides that look very similar to these. So we will always be able to tie things back to both where we thought we would be over the 7 years, where we are related to the budget, and then where we are related to this specific year's spend, and then what we're proposing for the following year. So I hope that this does start to get to kind of that level of financial detail, at least as it relates to our kind of 7-year healthcare equity implementation plan and then our annualized priorities process. And now I'm going to hand it off to Alan.
All right. This is exciting. I think for specialty care, next year is about building to scale and also adding services. So I'm going to touch on briefly kind of the clinics we have up and running and the clinics that we will have up and running. As you all know, we East really started off, with podiatry, with GI, with pulmonary, and a little bit of wound care thrown in there. Next year, and since then we have moved, GI and Pulm out to Capitol Plaza, and really, then taken a step forward as far as expanding access to podiatric care. Next year is really about scaling. We have just initiated our ABIs and our TBIs, some more diagnostics for podiatry, added wound care, and will continue to increase access. as well as making sure that, as few appointments go unfilled as possible. And so for our East Clinic, it's about, building to capacity and increasing access for our patients. For Capitol Plaza, we have GI and hepatology, and we'll be increasing access to those services as well as diagnostics, so endoscopies and colonoscopies. Infectious disease will build out to scale. The Bridge program, and I'll come back to the Bridge program in just a second, but the Bridge program, as I said earlier, is up and running as of last week. I think we've seen 6 patients with significant complexity, and I think Pat will touch on that a little bit later as well. Dr. Ashley Trust has been hired. She's our Director of Psychiatry, and we'll have psychiatric services, I think, throughout the system, but specifically at Capitol Plaza and then at RZ in a month or so when that opens. New service lines will be neurology and rheumatology, and then the diagnostics that will continue to be built out as well are ultrasound, and we're also working with our CUC partners to expand access to Suboxone therapy, which will be housed within Capitol Plaza. RZ will open in 4 to 6 weeks. Our cardiology service line should be up and running by the end of the summer, early fall. In fact, we actually got some news yesterday that we've hired another cardiologist who will start in December, early January. And so we've hired 2 attendings and 1 advanced practice provider. That service line will kick off in early fall and then scale. Pulmonary will continue to scale that with diagnostics, so pulmonary function tests, gaining efficiencies there, and also advancing our sleep medicine functionality and expertise. We'll be building out that programmatic approach. Nephrology, early fall, we will add a provider and start scaling that. As I said, psychiatric services will also be expanded to RZ. Medical optimization, palliative care, we'll have additional ultrasounds there, echo stress, and then pulmonary function. With all of these specialty lines, or with many of these specialty lines, there's also a programmatic aspect, and I'll use heart failure as an example. As we bring these providers on board, we need to work really closely with John's team and the operational folks. If you think about it, rather than be reactive to individuals as they experience kind of a heart failure exacerbation, if we can actually manage and monitor and educate those folks, we can avoid the heart failure exacerbation. Sleep medicine is another example. Dialysis and renal failure is another example. And so with all of these specialties, it's not just about patients coming in, it's about a programmatic build to keep people well once they enter the system. And so we will be maturing in all of those environments. As Monica said, we've also opened access to specialty care for justice-involved individuals. And, we actually had our first patient scheduled, and it's great news that the individual got released. Bad news for us because that would have been our first patient, but good news for the individual who was released. And so those service lines, are up and running, and Monica spoke to this earlier, but we're working with our jail partners and seeing what their needs are, and then opening up access. And those lines of services will mature. Obviously, if there's a need that doesn't sit exactly within our direct practice, it makes it more complicated. Diagnostics, let's say endoscopies and colonoscopies for GI patients are an example. And so we're working through kind of the simpler access points to care, and marrying them with the critical needs within the jail, and then we'll advance as time progresses. As related to our bridge team, so our bridge team is really our complex care team for our patients. Now, mostly we're going to be working with unhoused patients, but there are 2 aspects to that bridge team. There's an in-clinic presence and there's a mobile presence. The in-clinic presence kicked off last week. And there are three phases to that in-clinic presence. The first phase is really caring for our patients who sit within respite. We can do relatively minor medical care within a respite environment, but for the complex care that needs to be conducted for those patients, they're brought to Capitol Plaza and we provide that care. Later in the summer, early fall, we'll be working with our EMS partners. EMS estimates that there are about 65,000 outreach calls that they receive where patients don't need to be transitioned to the emergency room, and about 10% of those patients or those calls really qualify as our patients. So the next iteration of that bridge team, now we're not going to have 6,500 patients being brought to the clinic all at once, but we're working with our EMS partners to make sure that if they get a call and the patient is ours, that they have access to bring those patients to Bridge Clinic where we can care for them, provide wraparound services, and keep them within our environment, if appropriate, transition them to SNF or respite or wherever else, and then potentially, transition them to their primary care home when is appropriate. The third iteration for the in-clinic presence is our justice-involved individuals. When they are released to wrap the complex care, they will have access to the Bridge Clinic. The next iteration is the mobile team, and the reason we have a mobile team and an in-clinic team is this is the same patient population. For our mobile team, it'll be comprised of, internal med or family med doc, nurse, psychiatrist as need be, community health worker, peer support, and MA. These teams receive, undergo traumatic experiences relatively frequently as they care for the high complexity of patients on the street or in some of these environments, and I'll touch on those environments. And so as we are able to have an in-clinic presence and a street presence, those teams then change places. So we may have a team in clinic on a Monday, Wednesday, and Friday, and that team would be out on the street, on the opposite days, and vice versa, so that the teams not only get some respite themselves, but can also follow up on their own patients. As related to our mobile teams, this is going to be the team that will be caring for our patients within kind of our diverted care environments with our partners with Integral Care. This will be our team that also works within the shelter environment, and this will be our team that also cares for individuals who have recently been housed. And so the complexity of these, bridge in-clinic and mobile teams is it's pretty advanced, and I think we'll meet a good deal of the needs that we're currently not meeting. As related to psychiatric and behavioral health care, we have started that care. We will build to scale. We will also look at methodologies for care. So not only in-clinic presence, but telephonic, video, and other modalities of care that serve our patients best. We'll also continue to work with city, county, and our mental health authority experts to build out a care continuum. So we're not just treating a disease, but really able to care for patients as they transition through the system. We will continue our planning for the Austin State Hospital campus, which again is a part of that care continuum. And I will hand it off to Ms. Morgan.
Great. In the same strategic imperative area of access and capacity, I'll speak to 4 additional community need areas. Would you do the next slide? Thank you. So the first being creating robust post-acute care, including respite and extensivists. As we've discussed, this year has really been focused around our contracted beds and increasing contracted bed capacity for medical respite to the extent possible. I think we are largely exhausting the available beds in the community right now, and speaks to the work that we have ahead of us. Establishing the bridge team to provide medical services for those patients in the respite environment, and also establishing our skilled nursing practice, as well as following those patients as they discharge to home or into a respite environment. FY '25, in terms of our strategic priorities going forward, starting to do the design work for the Cameron Road facility. And as Alan mentioned in the early wins presentation, we're looking at multiple opportunities to really advance the timeline on the medical respite work, and hope to have some exciting developments to share with you all here soon. We're also expanding those skilled nursing teams. These are highly complex patients coming out of the hospital, both medically and socially. We have robust teams that are in the skilled nursing facilities on a daily basis caring for these individuals. And we're maintaining around 35 beds right now in that environment. It is only meeting a fraction of the need in that space, so we need to add additional skilled nursing and care at home teams so that we can meet more of the need as our patients are discharging from the hospitals. In terms of primary care, including community care, HIV/AIDS program, and pharmacy, this year was about operationalizing the Hornsby Bend Clinic that's now open and running, as well as the Del Valley Clinic that is still scheduled to open later this fiscal year. Going into FY '25, our focus continues to be on the programming and build for the Hancock Health Center, and that scope of services, as well as continuing through the planning efforts around the Colony Park Health Center. So continuing to build access in multiple areas year over year. Substance use and addiction medicine services. FY '25, we're trying to get a head start right now, but we're trying to expand access on multiple fronts. Adding an additional team, as Alan mentioned earlier, through community care for medication-assisted treatment. We're talking with community care about programming that in alongside our specialty services at Capitol Plaza. We're expanding the methadone services through Dr. Oshbach's group, as well as community medical services. We're grateful for those collaborations, as well as the one with Integral Care for our patients with co-occurring substance use and serious mental illness. And as mentioned a couple of times already today, working with the Travis County Sheriff's Office so that we can enhance access to continuity of substance use treatment while people are in the jail. So really excited about the efforts there. The goal going into FY '25, particularly with MAT through community care, is getting to same or next day reliable access for inductions. We're not quite where we would like to be. There's been a lot of investments across the community in substance use treatment access, but we really need to get to same and next day access reliably for those inductions. To that end, we're also working with the City of Austin and the Austin Travis County EMS Department to really support some of the services that they've put in place that's also helping with opioid induction or opioid treatment inductions in the field, and then connecting those patients to care in the community care environment. So we're excited about advancing that relationship as well. Another new line of effort in terms of substance use treatment is really in the harm reduction space. We are really starting an effort right now, but it will certainly start to ramp up going into FY '25 around enhancing access to naloxone throughout the community. The City of Austin, Travis County, many others, I think, are doing work in this space today, and we're trying to better understand that landscape and figure out where we can supplement the efforts of those other entities with a goal of getting to saturation of naloxone here in Travis County. Again, a long way to go. I think this looks like Central Health, in partnership with others, including community care, purchasing and operating some naloxone vending machine type options, as well as helping to provide naloxone to some of our partners in the community organizations that are running our shelter environments or other places where where we can make naloxone available both for their staff's use as well as to give to individuals for personal use. So there's a lot of planning going on in that space right now, but we're really excited to help take on and tackle that particular concern in the community. In terms of expanded access to dental care, the Del Valley Clinic that's coming online later this year has expanded primary care dental access. We've added additional specialty dental services in terms of oral surgery over the course of this year, and actually ramped up access in oral surgery pretty significantly this year. But going into FY25, really again, that focus is on these next two primary care sites that when we design a primary care site, we really hope to provide comprehensive services. So comprehensive medical, dental, behavioral health care, and pharmacy where we can in those health centers with community care. So really focusing on that, a substantial investment in dental services at the Hancock Center, as well as part of the planned scope of services for Colony Park. Next slide.
All right. As related to care coordination, program alignment and augmentation, we're continuing to scale our navigation and referral infrastructure. I also touched briefly earlier on as far as the programmatic build that we're doing. We've also transitioned our care coordination team from a reactive team or teams to a proactive team. So we know individuals that utilize the system more frequently, and we have proactively enrolled multiple cohorts of individuals into teams that, when unstable, are actively managed. When stable, are transitioned more to a monitoring arm, so that there's a different team that actually provides outreach and can continue to ensure that those individuals remain healthy. If there are any indications that they stand at risk, they move back into that complex management team. We will continue to expand those teams, and so we'll enroll more individuals in FY25 into those cohorts. As related to hospital care and management of our patients when they touch the hospitals, we're working mostly with Del Seton and Seton, Maine. We have individuals in the EDs and on the floors. We are not able to get to all of our patients who touch the hospitals or who spend time within the hospitals, and we are still working on advancing partnership with St. David's. Our individuals and transitions of care team are actually able to do warm handoffs with primary care providers to smoothly transition our patients from hospital to skilled nursing, from skilled nursing to respite, and from respite to care at home. So that environment has been built over the past year. Those will all scale within the next year. We're adding 4 teams to our hospital environments, and we think for Del Seton alone, there may be an additional 4 teams in order to get to every patient. So again, we're going to take a step, try not to give Jeff kind of a heart attack, and so we'll take a step this next year and then another step the year after as we really build out to scale and try to get to all of our patients. We continue to strategically approach our social determinants of health and are working together as teams to affect the elements that sit outside of our care environment that ultimately affect the care of our patients. This we will do when appropriate, internal to Central Health and with partners as is appropriate. Food insecurity has kind of risen to the top, and so we're working with our team members to determine what the next step is. Included in this bucket is the next iteration of our community health care initiative fund, and so that will roll out over the next year. Next slide, please.
All right. I will speak to the strategic imperative around member enrollment and engagement. I was reminded as we started the joint eligibility work with community care that just over 4 years ago, all eligibility and enrollment into the medical access program occurred in person, face-to-face. A patient had to, community member, patient, applicant had to travel to a community care, a central health eligibility site and complete an application in person. We now have a eligibility call center. We've got an online application, and close to 50% of our enrollments and renewals are taking place through those other mechanisms. We've also, over the past year, really focused on virtual enrollment assistance and how we can take eligibility to our patients instead of having our patients have to come to us. We've also had a renewed focus on eligibility services for individuals experiencing homelessness, and those are a lot of the themes that I think will continue into FY25. We talked a lot about the goal shared with Community Care and Sendero in the prior presentation, so I won't go into a lot of detail there. But I will touch on these next two bullets that we're very pleased that we're able to now offer MAP eligibility services here at Cesar Chavez. It's only a couple of days a week at this point, but as we move into FY25, we want to make that a 5-day-a-week presence, as well as having some dedicated outreach capacity for our eligibility specialists to go to shelters, to go to supportive housing environments, and help enroll our patients more on the spot. We're also working with the Travis County Sheriff's Office, as mentioned, not just on the clinical front, but in terms of helping more with the enrollment of inmates into the medical access program, so that both as they're in the jail and after they leave incarceration, they have coverage and can access care more readily. So we are assisting with the enrollment classes at the jail, and we'll continue to refine that work and look for opportunities for improvement. We will also continue to focus on the virtual enrollment that I mentioned. We started virtual enrollment first at the Care Connections Clinic, where community care is mainly serving individuals experiencing homelessness who are more complex and discharging from the hospital back to primary care. We've actually had a lot of success with that model. We then extended that same model to our teams who are working in the hospital, so that while folks are still in the hospital, we're able to help get them enrolled in the appropriate programs. And then more recently, we've added virtual assistance to eligibility for the Hornsby Bend Clinic as that opens. So that's another tool in our toolkit to extend enrollment and eligibility services, but also do it in a very efficient manner. If there's not an individual in the clinic for eligibility at that moment, that same staff member who's servicing the virtual enrollment can be working online applications on the back end. So there's a lot of opportunity to really flex those resources. We're also going to be expanding our eligibility services so that anywhere we're offering clinical services, East Austin, Capitol Plaza, Rosewood, Zaragoza, we're going to have on-site eligibility services there to help assist our patients. I'll mention that right now, we're fortunate that both MAP and MAP Basic, because of all the outreach efforts and because of our direct interactions with patients, both of those programs are at all-time highs from an enrollment perspective, with just over 31,000 members per month in the MAP program and over 50,000 in MAP Basic, and that's on a pretty steady growth trajectory. And finally, our patients, and Manager Jones mentioned this earlier, do experience gaps in coverage, and we do want to continue to have a stated goal of Central Health be to extend to a 12-month enrollment period for the MAP program. Re-enrollments and renewals are a challenge for our patients. We are doing everything we can to help close that gap and to develop interventions to help people renew their coverage in a more streamlined manner, but that is a goal that we will continue to pursue with our partners at Ascension.
And thank you. In the interest of kind of time, I'm not going to read through every one of the items on the next slide. I think that it's really important for us to all to note, though, that there is an ongoing commitment to strengthening our organizational infrastructure so that as we build up our clinical capacities and continue on this very fast growth trajectory, that we are able to kind of keep up the support functions and operational functions that will allow us to succeed in that implementation. One key area is in health information technology and our joint technology area. And I'd just like to note for John Clark in particular that our prior and ongoing investment in that area and in our IT infrastructure has us poised today not only to securely provide the expansions that we need in the IT area to support the ongoing functions, but to fully explore new innovations and to explore things like how we're going to approach AI as a system, and that work is ongoing. And also, we are continuing to scale our general joint technology in a way that it maintains data security. And then also in the foundational enablers area, I'd just like to point out there are many areas that both align with the people and culture HR focus that Jeannie mentioned during the previous presentation, and also around system alignment, consolidating and aligning workflows and processes in areas that we are able to with community care in Sendero, and to exploring areas where there might be efficiencies by taking a more systematic approach, in addition to the ones that were mentioned in the previous early wins. Next slide, please.
A few staff emerging priorities just to make the board aware of going into the new fiscal year and the budget presentation. These are things that we didn't necessarily set out at the beginning of the year to do, but want to raise these for awareness. The Capitol Plaza Clinic that we started services in as a transitional site to get us to Rosewood, Zaragoza will be consumed by the highway expansion. It's right on I-35 on the frontage road there, just north of the split. That site will go away, and one of the things we are really focused on is making sure every service there has a place to land in the future. So that's moving services into Rosewood, Zaragoza, but also likely using that clinical education center space as a bridge towards the later Hancock facility that would open. We're also really trying to make sure that as we are growing, as Community Care and Sendero are all growing their missions, that we're doing that as efficiently as possible. So we're really working through a process with our partners to look at things like joint technology, that human resources, at instrument sterilization, all kinds of examples of places where we might be able to gain efficiencies. And then you're very familiar at this point with the Travis County Jail work. One area we'll call out here is there's the highest cost areas for the jail to operate in terms of healthcare are related to HIV and hepatitis C care. So we're hoping that we can both help the jail with their costs associated with those services, but also to help with continuity of care in those areas and help connect patients with services post discharge from the jail.
There's a significant need to continue to build out the care continuum for mental and behavioral health. I think we've touched on it several times tonight already. We'll work, within Central Health and then with partners to ensure that, over time, fewer individuals fall through kind of the gaps of care and continue to build that. We've spoken about the bridge, both in clinic presence and the mobile team, and so significant efforts will be concentrated on that. And then as far as kind of whole person care, we need more respite beds. We need individuals to sit in respite for a longer period of time so that we can get them housed. We need to work with partners in order to ensure that housing is available. And so that is a care continuum in and of itself, and so we will continue to concentrate efforts over the next year in that space.
Next slide, please. We can go one more, please. So I'd like to thank all of the managers for participating in this collaborative process. It is a new process, and so I also appreciate your patience and kind of enthusiasm in going down this road with you. On this this slide, there is a brief summary of each of the recommended board member emerging priorities. I also am not going to read through each one of these because today is just the first time we are setting these out, and it's our first review of these member recommended priorities. And then on the next slide, the staff recommendations based upon these priorities, looking at impact, alignment to the healthcare equity plan, financial and legal feasibility, value, complexity, and sustainability. And there will be additional, I think, you mentioned possibly, Manager Brinson mentioned July 17th as a possible meeting that will be primarily focused on more fulsome discussion. And then there's also opportunities, if you would like to reach out over the next month, to schedule a discussion or one-on-one to either refine how we've summarized the proposed priority, or just to ask questions about your proposal. And this is our final slide of this presentation. If you look on the left, we've noted areas on this left-hand side that reflect where the staff perceived alignment of recommended proposals to existing priorities. On the previous slide, it was more a summary of what the proposal contained. This left-hand side of this page really is staff's interpretation and perception of ways that we're working that seem to align with the manager recommendation. And then on the right, there are recommendations where staff believes that either moving directly to an RFP in the area, it's so closely aligned with work that is underway, or that you've heard about in kind of ongoing staff proposed strategic priority work, that we would move straight to an RFP, such as with the area that Dr. Shalsha mentioned. We have the Community Health Initiatives Fund program that is in place that has funding that's kind of ongoing and allocated toward that. We've been doing internal work around alignment around social determinants of health priorities. And then there were two proposals around food insecurity and food as medicine. So there's very close alignment with kind of ongoing internal identification of need, community identification of need that came to managers during community conversations, and kind of an ongoing program that we develop a scope, additional scope of work for, related to the food as medicine and food insecurity. Also, Manager Valadez, the work on the Hispanic Family Support Conference is already underway. So moving that forward and creating the funding to move that forward to RFP so that we can get that implemented next year. Also, I apologize, Dr. Manager Musaitif, there is a typo in our kind of proposal recommended related to your proposal that was recommended, but we would recommend that this improving cancer survivorship through data sharing, targeted training, and enhanced transitions of care would be something that we would develop through what we refer to internally as a business case process. Every proposal that was on the preceding staff pages went through this business case process. It's a kind of fulsome development process so that we can determine how things would be funded, and they would go directly into implementation. And then also, there was a proposal for developing, for expanding MCOT teams to meet the needs of the central health population. And we would recommend that that would go into the full kind of business case planning process. And of course, that would be added on to our ongoing collaborative work with Integral Care.
Wow, that was a lot. Okay, so very interesting, very fast. Yes, Ann. Manager.
Oh, I just want to say that, thank you very much. This is a lot of really good information. I'm looking forward to, I think our meeting is in July 17th, to get into greater detail with questions. I think we could probably spend that time to really get into greater detail on the board recommendations, but we could also spend that time if we want to talk more about the, the other the recommendations that you went through that are part of the health equity plan. So I know this was a whole lot of work for you all to put together, and I really appreciate it. And I want to say thank you to the rest of the board too. I mean, there was a lot of interesting things brought up, and I think this board can really get into those on July 17th. We can also, between now and July 17th, we can reach out to you if we have questions or if we want to just talk more with you guys about what our particular proposals were. So I just wanted to say that.
Thank you. Yes. And Manager Besaita.
Yes, thank you all. I echo everything the chair said. One thing about the July 17th, just want to let you know, I will not be here. So either I'll designate someone to carry on that priority item. So just FYI, so however you want me to work with you on that. Thank you.
And Manager Valadez.
Thank you. When you talk about the FY25 strategic priorities, the last item on that page with respect to the social determinants of health, and you say that we're going to implement an organizationally aligned strategic approach to non-medical drivers of health, and I ask how. Is that going to be in partnership with other priorities, with other agencies who are responsible for doing those things? Because those really aren't direct services, and I just wanted to see if that's what we're assuming, that we're going to bring partners to the table that are going to actually do that work.
And the only social determinants and non-medical drivers that we are working in are non-medical drivers that are directly related to health and healthcare. And also one of the reasons that we would approach that through an RFP process is because we would be working with contracted providers who would do that work.
Great.
So, thank you.
And then, on the access to mental health services, I saw that you all threw in including Austin State Hospital campus service planning. That's the first time I've seen that, because that's a state agency, that's a state responsibility, and they're responsible for that. And if things are a mess, it's because of the political leadership there. That's all I can say. But with respect to us, what are we going to be doing with them? Sending them people? But, just like referring, I'm hoping, not any more than that.
What page are you talking about?
Right here in where it says access and capacity.
Okay.
Access to mental health services. At the very end,
Oh, I see.
collaborate. At
Okay.
the last, including Austin State Hospital campus service planning. I didn't want to open any door to state agency contracting with us or services or expenditure of our tax dollars on that, because then we may as well, let's go to the brain center that Watson wanted to create, or let's talk about something else, or let's talk about something else. And sticky, for me, it's sticky when we start going on to state properties. And I'd like for us to remain at Travis County as we were created to do. And so what are we talking about there?
Perhaps I could take that question. So thank you for raising that, Andrew Valdez. And I think all of us would acknowledge that the level of collaboration and thoughtful partnership required to do work in that space is complicated, and we certainly appreciate that. The reason why we are engaging with our partners, all of whom you see listed here in that box, is because this is part of the continuum of care. The problem of patients who are stuck in the jail setting, unable to restore competency, is linked to the care continuum that includes the Austin State Hospital. Whether or not patients who are currently in that hospital have the continuation care they would need to step down from institutionalized settings and begin to adapt to care in less acute, less institutionalized settings depends on the presence of that continuum of care. It's complicated but necessary. We have bottlenecks in the flow of patients through our system that many folks who've been in the community for a long time, some of the advocates who are with us tonight, I believe, have been clear on this, that there's a need to allow patients to flow through different parts of the system. And because these are very much our patients, we have a shared responsibility for participating in the conversation of how we create that rational flow through the whole continuum of care. It's part of the whole person care at scale effort that we're engaged in. We're not standing alone in that, but I think we are at the table and need to be at the table.
I appreciate that.
Can I say something first?
Let me finish.
No, let me say something first.
Yes, ma'am.
Okay, because I want to add on to what Dr. Lee is saying. I'm not reading this as Central Health taking on services that the Austin State Hospital is responsible for. What I'm hearing is perhaps they're a partner to talk to, just like we might talk to everybody else about the services that we're responsible for. And so, like I think you were mentioning, if we're going to be looking at services that are, if we're going to pick up somebody who's discharged from the state hospital, we might need to talk to the state hospital as we plan on how we're going to pick up somebody that's discharged from the state hospital. That's what I'm reading this to mean, not us doing something that they're supposed to be doing, right?
That's right. Or, for example, if there's a patient who doesn't need to go to the Austin State Hospital because we can stabilize them in their time of crisis and find another way to care for them without them having to be hospitalized. That's also care that we're engaged in with integral care in the county. So there's a flow of patients through this system that we need to address. Yeah, but
I thank you very much, Dr. Lee, for saying that. However, what this does show me is that we really need to have, and I know Shannon will second this, our retreat, so we can talk about definitions, who our population is, what we need to do for our population, and get that taken care of before we hit the budget session. Because I think that's going to be imperative that it be addressed prior to looking at numbers and budget allocations. And then I did have one last thing. Okay, great. And then I did have just one more quick snippet. As we're looking about the development of the healthcare workforce, including the RN education program, let's try and create the Central Health Promotora CHW program. Thank you. Oh, and on the, where you talked about MAP and MAP Basic, if we could also have our chat numbers given to us on that regular basis. Thank you.
And Dr. Martin, Manager Martin.
Thank you. I'd like, before I ask my question, I'd like to sort of reiterate maybe perhaps how the mental health system works a little bit. Say someone is acutely psychotic, they're taken to the jail, they're not stabilized mentally. We don't have a mental health hospital. Instead of a partnership where they can be stabilized and then transfer back out to us, I think that this is what that's alluding to, is that conversation has to occur because they bounce back. We don't have a mental health hospital that we own as Travis County. And I think that simply as stating that we need to coordinate in partnership with these people.
I think that's why I said it's important that we have a discussion about, and all come to an understanding about what definitions are. Thank you, and processes.
So I do have a question, that's about the continuum of care, Alan and Jeff. So say someone we see that has a bad ABI, a bad vascular problem, they need a CT angiogram, or a stent. How does that process, continuum of care, going to happen? And how would it be accounted for in our expenses, et cetera?
So currently, Ascension still has primary responsibility for that care. And so we would coordinate with our Ascension partners to ensure that, the patient got that care.
Okay, and how is that, I guess when we're bundling about what cost of care was for the year, say for cardiology, how is that budgeted out or presented to us?
Could you ask that second part again, sir?
Well, say they get a bill for $60,000, Ascension says this cost me $60,000 to put stents in, whatever. Their response for that, how does that allocate it in our budget? It's not at all.
Well, and this, I don't, there, Jeff is with us. So, the way that, the expenses for the hospital side or the downstream side of care are part of our budget is through the omnibus services agreement. It's through the value of services in the agreement. And so through that value of services process, where the DISH and the UC funds are kind of the first payment received to cover Central Health's contribution to that value of services.
Thank you.
Yes, Manager Motwani.
I want to echo Chair Kitchen's comments. And, this is a gutsy thing to do. I appreciate leadership doing this, putting out priorities to the board and trusting us to submit cogent recommendations that will largely align with where we're going. And you can trust that we'll do our best to own our side of that trust. So thank you for that. And I also want to say I'm just uniquely fascinated and interested in the staff emerging priorities, and I appreciate the inclusion of those. Thanks.
Manager Jones.
Yes, thanks very much. I can concur with what my colleagues have said. Just a couple of quick things. One is on the board members, particularly mine, that's one I can refer to. That was another one, and I'll talk offline with you about it, that I don't see somewhat representative here, so I'll ask you offline. The other thing is that, and thank you, Manager Valadez, I do think that we need to, as soon as possible, and maybe we're going to set a date today, move on having a retreat so that we can begin to be. Yeah, we can talk about that on that item. Okay, or is it on? I didn't see
It's on the executive committee.
Oh, okay, then I just want to encourage it.
Yeah.
May I say something? If I may, please.
Oh, yes, please, Manager B.
As the newest manager on the block. Oh, sorry. That shows you how new I am. As the newest manager on the block, I just want to say that I'm very impressed with the work that's being done, the ambition that you've taken on. And from my perspective, while I don't have all the history, having worked with the board, but I really believe you've got the pulse right on where it needs to be for the services that this community needs. And I also believe that you've got the right staff and the right commitment. I do believe also that this board is going to see to it that we move forward. There's some new things that have come online and some new areas that I'm going to discuss with some of you all individually, because I think it's still premature for those items to come up, because right now we've got a lot on our plate, but I'll bring those forth as some individual conversations and see if I need to visit with you guys or visit with staff first and just figure that out. But I'm very impressed, and I'm very happy to be doing this work with you.
Thank you.
Thank you, Manager May.
Manager Motwani had another issue.
I'm sorry, I wanted to append something to this statement I shared earlier, which was that, in addition to this being gutsy, it's very much the right thing to do. And I think we see that in as much as how circle of communication by means of, for example, community conversations is being closed, or at least it's looping through our governance and decision-making process by means of board managers who are effectively stewarding the community input, while, of course, intercalating our own expertise and thoughts for staff's review. So that's a really beautiful process, and I just want to honor that. And also, the engagement's been profound, and I'm sure this is just one example, but I got a call from the CFO, and we spent an hour noodling around on ideas to make sure that, you know, one of my recommendations was presented appropriately and to manage my expectations. And that's an expensive call. I mean, both of our time must be worth $20, you know? And I really just appreciate that process. It's very, very thoughtful.
Madam, may I build for a moment? I think in your proposals in particular, you called out that ideas had emerged from the community conversation that we had a few weeks ago. And so I think you referenced that, but I would just underline how cool that is, that our community showed up, and then our managers showed up. And for those who weren't there, including speaking to the public, if you had been there, you would have seen about 50 members of our community, I may have that number approximately right, breaking out into tables of 10 people with a manager each at the table and having that dynamic conversation for items from those breakouts to find their way through to your proposals and then through to our budget. That is the kind of engagement that we're aiming for. We're just getting started, but thanks for lifting that up, and thank you for bringing those ideas forward in this venue.
Thank you all. Well, we're moving into the home run here. So item number 4, receive an update on the Central Health dashboards associated with service level reporting for fiscal year 2024. And this is an information only moment.
I don't think we were going to talk about that one, right?
I think there's information in the packet. We're happy to answer questions offline if useful.
Confirm the next strategic planning committee meeting date, time, and location. So our next Central Health Strategic Planning Committee meeting is tentatively scheduled on Wednesday, August the 7th, 2024 at 1 p.m. at the Central Health Administrative Offices, 1111 East Cesar Chavez Street, Austin, Texas, 78702. And at this time, I am ready to accept a motion for adjournment. Manager Valadez suggests the motion for adjournment, and do I have a second? Manager Kitchen, well, as our second. Would everyone vote, please, on that? Yes. So, all in favor, say aye. Aye. Oh, thank you.
Actually, I get people's attention. Okay, good afternoon, everyone. Today is June 12th, 2024, and it is 5:15 p.m. And we are, as a quorum of the committee of this Budget and Finance Committee, I would like to call to order the meeting of the Central Health Budget and Finance Committee. As a reminder, some of our committee members, I believe we're all here, so I don't need to mention that. Now, gonna go a little bit out of order really shortly. I know that we have a time certain of a 5:30 p.m. public communication, but because we are in the opening of our budget season, I want to give the opportunity for committee members to speak before us before we go into our meeting. So at this time, do we have anyone who have signed up for this committee that would wish to speak at this moment or would like to speak after this meeting? So just wanted, yes, for the Budget and Finance Committee. Okay, so you're 5:30. So is there anyone that would like to speak before our committee? I see none. Okay, thank you. So we will not proceed with public communication for this meeting at this moment. Now, I would like to proceed with our committee agenda. Committee item number 1, approve the minutes of the May 2022-2024 Budget and Finance Committee meeting. I move that the committee approve the minutes for the May 2022 Budget and Finance Committee meeting. Do I have a second? Chair Kitchen seconds. Any discussion? All in favor?
Aye.
Motion moves. Thank you. Now moving along to item number 2, discuss and take appropriate action on a recommendation of the Central Health tax year 2024 homestead property tax exemption rate and homestead exemption amounts for Travis County residents who are over 65 or disabled. At this moment, Mr. Jeff Knodel and Nikki Riley will be presenting. Thank you.
Thank you. We will try to be brief on this, but there's a lot of detail. So I'm going to kick it off and then turn it over to Nikki for the presentation. We can advance the slide. Thank you. So we are asking for action for this item, but let me clarify, the action is really a recommendation to the Travis County Commissioners Court. We're here today to discuss the rate and the amounts for what are 3 optional tax exemptions. We traditionally make a recommendation every year. The 3 exemptions are the homestead exemption, which is typically a percentage, and I believe ever since the inception of Central Health, it's been a 20% amount, which is the maximum amount set by law. And then setting the over 65 and the disabled exemption amounts. Again, you'll probably hear Nikki mention that this is a recommendation to the Commissioners Court, who eventually sets the rates and the amounts. And then lastly, but not certainly as a comparison, as part of this presentation is comparing us to other organizations, but just keeping in mind, I try to do simple math now. So our tax rate's about 10 cents per $100. We're also going to look at some county recommendations, and the city has recently adopted their optional homestead exemption amounts. But I just wanted to keep in mind that our tax rate is 10 cents, rounding. The county is around 30 cents, and the city's around 40 cents, 45. So just keeping in mind that as you hear about impacts from other taxing jurisdictions, that those amounts are larger than that simply because of our tax rate. So I will turn it over to Nikki for the presentation.
Good evening. Like Jeff said, we're here to come give you some data on the 3 tax exemptions. Homestead at 20%, which Central Health has been at 20% since inception. So is Travis County. They have also been at 20%. I believe City of Austin did not have a homestead exemption until about 2015. And then they have now ramped that up also to 20%. So right now, the history of what our exemptions have been in the past is the 20% homestead exemption. That comes 20% right off the assessed value. And then over 65 and disabled are both at 124,000. You don't get both of those exemptions. You only get one. Let's say if you're a senior and you're disabled, you get the $124,000 exemption. For fiscal year 24, City of Austin, Travis County, and Central Health had all the same rates and amounts for the exemptions. So far, City of Austin has approved 154, sorry, I'm getting ahead of myself. The next slide, please. For fiscal year 25, City of Austin has approved $154,000. I've been in contact with Travis County Budget Office, and they're going to be recommending a 10% increase over last year. And that would take it as to 136,400, which is a 10% increase from what we had last year.
And sorry, we have a typo.
Yeah, we do.
It says 136, comma, 00. That's 136,400.
400.
So, sorry about that.
136,400?
400, yes.
Yes.
Central Health has always been in line with the county, but we are here to ask for a recommendation from the Board of Managers to Travis County for them to adopt. The next slide, please. So the property tax exemption analysis is kind of looking at the property tax rates and how it affect the average taxpayer, average homestead taxpayer. For fiscal year 24, the average homestead was $475,286. And the 20% homestead would save $95.71 in property tax. And the over 65 and disabled at 124,000 saved $124.86. What we're proposing for fiscal year 25 is a 6.5% over the no new revenue rate. The latest calculations that we got from TCAD, the average homestead is $489,548. That changes on a daily basis, but that's what it is on the latest calculations. The tax rate for 6.5% over net new revenue is 0.104393 per $100 of value, bringing the tax bill to $511.05. 20% homestead exemption saves $102.21, and then we are recommending a 10% increase on the over 65 and disabled to $136,400, which would save $142.39. The City of Austin at $154,000 over 65 disabled exemption would save $160.77. The way the tax effective tax rate works is the savings from this set of taxpayers gets pushed to other taxpayers. We do not lose those dollars at Central Health. And so we asked for the scenarios, the three scenarios from TCAD on these three, 124, 136, 400, and 154,000. What that looked like being pushed to the other taxpayers, homesteads. At 136,400, it would $1.30 would be pushed to the average homestead, and at $154,000 exemption, $3.13 would be pushed.
Nikki, if I may.
Yes, ma'am.
So those individuals that will be pushed could be our population that we are serving who are underserved and uninsured, correct?
Yes.
Thank you.
Can I make a comment, please? They're only pushed, pushing it depends on what our tax rate is set at, though. Is that not true? You are assuming this based on the same tax rate we have right now, is that right?
This is based on a 6.5%.
Which is what we have
rate
now.
over net new over the net new revenue.
Okay,
Yeah.
gotcha.
Again, it's preliminary. We won't have a final tax rate until we get the certified tax roll, which is usually the end of July.
Okay,
So-
that's fine. The point I'm making is just that if this, it's not, whether or not it's pushed to someone else, including our members, depends on what our tax rate is set at. That's all. I just wanted to be clear.
Okay, next slide, please. So this chart is, we did get a list of all the parcels that are eligible for the senior and over 65 exemption. There's a little over 77,000 parcels. So the count, the chart that's on the left, 48% of those parcels are under 300,000. 33% are over 700,000 in value, and 13%, I'm sorry, I said that wrong. 33% are under 700,000, and then over 700,000 is 13% of those parcels. And if you notice there's 6% or zero, that means that they had another exemption that took them down to zero. So no taxes due. So on the right is the value. There's about over $30 billion in property value, and 41% of that value is in properties that are over 700,000. 38% are under 700,000, and then 21% of the value are for homesteads under 300,000. Next slide, please. That's it. Again, our recommendation would be to stay in line with Travis County. They're the ones that actually adopt and approve the exemption rate. We've always been in line with them. And so we would recommend that and ask that you take action.
Thank you so much, appreciate that. There's a motion at the table. Can we take that motion and then we can discuss it?
Okay.
Manager Valdez, you want to read that motion?
I was gonna make 154,000.
Yeah, so was I.
But can you, so your motion,
My motion is that we accept the $154,000 dollar amount exemption for our disabled and over 65.
okay,
And that we can hopefully convince our county commissioners to do that.
And I'll second that motion.
so just to make sure that, I just wanted,
We have a motion on the table.
so we have a motion at the table, the 154 that your manager Valdez, not the recommended staff, not the recommendation. Not the staff recommendation. So, and we have a second by Chair Kitchen. Now, discussing this item, there's a couple of thoughts that I have, previously what we've done historically.
Could we let the maker of the motion discuss it first?
Thank you.
Explain herself.
Explain yourself.
Please. The reason I say this is because, I'm sorry, I apologize for not having turned on my microphone. The reason I'm jumping to the 154 is as I live here in East Austin, and I deal with many people in my community that have been pushed out and away from their homes, not only here in East Austin, but in other places. And, you know, the amounts of money may not seem like a lot. Maybe cumulatively, they may be a little more. However, we still have people that are living in homes right now. Our property at 2407 East Cesar Chavez is over $800,000. That's just base, and that's not market value. That's what they're valuing at. So you think about how those residents that are still living in many in poverty neighborhoods are still having to pay those taxes with not a lot of relief in sight. And that's being done because the affordability question or the affordability issue in Travis County is not realistic for people to be able to live. And that's right now. And as we talk about, our poverty population are living under less than 200%. Even those that are renting still get hit with having to pay those property tax costs for the owners, many of which are absentee. So they're not even living in the same situation. But they're taking advantage of those that are struggling to survive and pay bills. And I think that, I would hope that our Travis County Commissioners would understand that 154,000 in the world of what appraisals are in Travis County right now is not significant. But it is significant to people who are having to pay those.
Thank you, Manager Valadez. Just wanted to make everyone cognizant, it's 5:32 and we have a time certain of 5:30.
I'll be very short.
Okay, thank you.
The reason I seconded it, and just as a reminder to everyone, last year, I may have made the motion, but one of us made the motion, and last year, this board recommended to Travis County that they use the same number for senior disabled that the city did.
That's right.
So that, there is precedent for us recommending that they look at the city level. Ultimately, as you all said, it's up to the county. So for the reasons that Manager Valadez said, and also just because this is one of the only areas that we can have some impact for our community, I just think it's important to make a recommendation, again, understanding that we're not the final decider, but make a recommendation to the county commissioners for the 154,000.
Thank you for that. So I think personally, again, I'm not opposed to that idea, but I just want to make us be cognizant of historically where we've been, and also not to add additional burden to our other constituents as well, members. So that is another thing that I am being mindful of with this motion that we have. It's, again, the commissioners are the ones who will make the final say, and I prefer that we always align ourselves with their commissioners, and also to understand that Travis County and the city we're not comparing apples to apples, just another thing to be very cognizant of as well. So I am gonna go around the table to see where our board members lie, and we will,
Can we just take the vote? Why don't we just take the vote?
We have a motion on the table.
Yeah, we have a motion on the table.
well, we're still discussing this item, so I just wanted to get the feedback from everyone else to give fairness, for all fairness. So that's the only, I don't know why this has just been a very difficult one.
It's not difficult. This is a fact of how to run a meeting and how to take a vote. And if there's a motion on the table, I can also say, call for the question.
Excuse me, I don't want to say anything in public, but I've ran multiple meetings prior.
That's not what I'm referring to. I can also say, I can call for the question.
Could I say one thing?
Yes.
I respect what anybody wants to vote on this. It's not an easy thing. You know, so I'm prepared to just see if people say yes or no, and I'm fine with whatever people choose to do.
I definitely concur with you. I think we're all on the same page here. We're not in a disagreement with whatever, and I think we all care for the community. Thank you, Dr. Zamora. So, all in favor of the motion that we have on the table? So, I have 3 votes for.
Maram, this is Omid. Can you repeat the motion, please?
Yes.
Is it the motion that's the recommendation? Or is it in it?
Yes, sorry, forgot that you are not, here. So the motion is for the homestead exemption for over 65 and disabled to align with the city of Austin of $154, $154,000, sorry. So that is the motion.
Okay.
The recommended value is to follow with the county. So that is the staff recommendation. So what are you in support of? Are you, do you vote for this motion that we have on the
And
table?
let's just take the motion is to recommend to the county 154,000. That's the
Yes.
motion on the table. So it's a yes or a no.
And right now, there's 4 people that have aligned themselves
So
with the
just,
motion.
yeah.
If I may.
Yes,
Manager
David.
Metwater, if you're going to vote, you have to have your video on.
Thank you for that.
Sorry. Is that you?
Sorry, he was here. Oh, gosh. Are you hiding?
Chair,
Okay, why don't you
Chair.
just take the vote again and we can raise our hands.
Chair, may I address council?
Yes, please.
Shannon and I are probably gonna abstain. Do we vote on this one? Because I just turned 65. I'm not gonna vote on it.
It's entirely up to you.
Is it okay to vote? Okay.
So, all in favor for the motion on the table of 154,000? So I have 1, 2, 3, 4, 5. So any abstain? Anyone abstaining? 2 abstaining, any opposed? So 1 opposed, 2 opposed.
Did you abstain?
I did abstain from this. So the motion carries?
Can I just make sure that so yes, the over 65 and the disabled exemption amount was 154,000. That's what you voted for. And you also voted for a 20% homestead exemption amount also? I didn't hear
We
that
didn't make that
mentioned.
motion. I'll
We
make
did
that
not.
motion. I'll make
Okay.
that motion 20%.
Okay. So,
The first motion passed.
Yes. So now we have a second motion.
so the second motion is for the 20% increased home exemption. All in favor? Any abstaining? No. So the motion carries unanimously for the 20%. Thank you all, appreciate it. Now I am gonna end this meeting for us to go into our public comment.
Okay. We'll now receive public communication for all of our committees and the Executive Committee and the Board of Managers. Members of the public who wish to make comments virtually during the public communication portion of the meeting must have registered with Central Health via the online form or by telephone no later than 1:30 p.m. today. As part of our public communication, we will continue with our Mission Moments series. With these brief presentations, staff, patients, or community members will share with us stories of how our mission is connecting people to healthcare and health coverage and giving them an opportunity to live healthier as Central Health builds a better healthcare system for Travis County. Because June is LGBTQ Pride Month, we would like to take the time to highlight the contributions they have made in the Austin community. So let me just say, board members, we will go through our public comment, our mission moment, and then after that, we'll take a short break so people can grab food. So, Yesenia, can you please introduce our speakers for this evening?
Yes, thank you so much, Chair Kitchen. I'll first read the guidelines for this meeting's public communication, and then I'll introduce, we have 3 public communication speakers and 2 mission moments. When called upon to speak, please introduce yourself by name before beginning your comments. Also, if your comments will focus on a specific item or issue on the agenda, please indicate the full item number. Each speaker will be limited to 3 minutes. Staff will be timing each speaker and will announce when a speaker has reached their time limit. To ensure the efficiency of the meeting, once we have let speakers know they've reached their limit, we will allow 30 more seconds to wrap up their comments before they are muted. Due to the restrictions of the Open Meetings Act, the board may be restricted in discussing any items that are not listed on the agenda for this meeting. The board may choose to set aside any new issues for discussion at a future meeting. I will call on our first speaker, who is joining us online, Mary Gowron. I hope I said that right. Mary, if you could please unmute.
Can we see Mary or no?
If they're able to turn their camera on.
Can you hear me now?
Yes, we can hear
Okay. And then start video? Okay, that's me.
you. Perfect, we can see you. Thank you, Mary.
Okay. Good afternoon. My name is Mary Gavron, and thank you for allowing me to speak with you. First, I want to identify and thank a Central Health staff member, Cecily Gaines, a Transitions of Care clinical advocate. I met Ms. Gaines when my son was a patient at Del Seaton this past February. Ms. Gaines was very helpful in confirming my son's mental health needs. He has multiple assessments confirming his condition, and paved the way for him to be interviewed by Social Security for disability benefits last Friday. She's an amazing person and a credit to Central Health. Ms. Gaines has communicated with me and is always available to discuss concerns for my son's mental health challenges and problems. That being said, as a parent of an adult son with a dual diagnosis who is currently on parole as a result of a psychotic episode, my concerns are focused on the current laws and policies that are not helpful to parents like myself who have no access and cannot provide input. Lifelong observations. This is not a problem that just occurred, it's lifelong. And these lifelong observations, we have no conduit. We can't advocate to mental health staff to assist and support clients like my son, whose condition is serious and dangerous to himself. He does not believe he's ill. I'm not speaking of a release of information. What I mean is a process for family members to advocate for their loved ones to mental health staff. I've experienced situations where my son has been placed in danger by mental health professionals who are either not able to identify his conditions or symptoms or realistically address his condition, schizoaffective disorder, other than provide medication. My experience with Integral Care, MCOT, Travis County Jail, Travis County Commissioner's Court, Travis County District Attorney's Office, Texas Department of Criminal Justice, Parole Supervision, Austin Transitional Center, local social workers, mental health staff, nurses, doctors, psychiatrists, hospitals, clinics, and dozens of nonprofit organizations have been frustrating, and at the end of the day, there are huge gaps in services and unrealistic expectations of clients who cannot meet the demands of self-medicating, paperwork, making meetings, or meet deadlines without someone like me, a parent. And yet, there's no way to verbally advocate on his behalf. I've attended meetings with Travis County Commissioner's Court for the Mental Health Diversion Center, and I wish for this type of program. But we need even more than that. When an individual with a mental health condition is sent to jail because of their condition, and then is paroled with no medical supervision or stable housing support, failure is almost guaranteed. During this meeting, I've heard many comments that ring true. And I pray and I hope, I want you to please continue to push for addressing the gaps and wraparound support for clients who, because of their mental health condition and encounters with the criminal justice system, are unable to succeed or survive. Thank you very much.
Thank you. Yesenia, who's our next speaker?
Thank you, Mary. Up next, we have
Thank you.
Sunny Ali, who is joining us in person.
Thank you for advocating.
Oh, yes, yes.
Thank you for giving me a chance to speak here. My name is Sunny Ali. I'm a solution consultant with Toshiba. I was coming here today to really make some recommendations, but I had a chance to see Dr. Lee's SWOT analysis and some of the information you presented, and I just wanted to make some comments related to that. One of the issues brought up was a weakness being the technology and the systems, and that Central Health their growth is outpacing the current systems. That is a very real weakness that is being felt in terms of the burden on the staff, and that translates directly to one of the other issues that you brought up, which is employee retention and satisfaction. As a consultant, I work with a lot of companies, and I found that some of the best places to work are those places where they've invested in a technology that enable the staff to be as efficient as possible, and that gives them a better sense of accomplishment, makes them feel that they're having a true impact, and that goes to their satisfaction, how long they stay with the organization. So I believe that the technology is not only a weakness, but it's an opportunity to, as you also go through this time of rebranding for Central Health and the families, this can also be an opportunity to unify in the terms of digital transformation, in terms of software and technology that can facilitate better communication between the various components and simultaneously have some of the other benefits such as improving employee morale and also ultimately improving the outcome, which is healthcare. I think that's about it. Thank you very much.
Thank you.
I'm just offering my assistance. I'm a consultant. And
That's
so
okay. That's fine.
yes, I will give you my card and happy to talk with anyone at Central Health that is willing to listen. Thank you.
Thank you. Okay.
Thank you, Sunny. Up next, we have Sonia Burns, who's in person with us.
Can you hear me? It's on, okay. I tend to go over, so I will try to be as fast as I can. I'm Sonia Burns, and just context quickly, I have a twin brother who's been living at the Austin State Hospital for over 15 years in this admission after cycling many more years before that. He's got, he lives with autism, traumatic brain injury, partial lobectomies of each temporal lobe, major frontal lobe damage, think executive functioning, bipolar disorder, PTSD, OCD, a silent seizure disorder. He is not the sum of his diagnoses. He's an amazing person. He's been there this time on a civil and now 5 years as voluntary, and we have no place to go. And I did not know that when he had a head injury at age 21, there would be nothing for him. Now I've become an expert. I sit on the Judicial Commission on Mental Health, the Collaborative Council. This is when the Texas Supreme Court and the Court of Criminal Appeals came together to address persons with IDD, SUD, SMI, serious mental illness going through the criminal legal system. I also sit at the HHSC Legislative Advisory Committees on the Joint Committee on Access and Forensic Services, State Hospital Beds. Okay. I work at the local, state, and federal levels, and I am regretful that I have not been coming here for many years. I wish I could go on your retreat because there are so many things you all do not know. So when we're talking about the most complex needs, we have nothing. We have nothing. They're not going to be served in anything we have, and psychiatric stakeholders under David Evans, I am glad he is finally gone, had a convening over a year ago to address these persons with the most complex needs. What's missing in the continuum? And one of the recommendations was a secure setting. I am working very closely with legislators. We have nothing under regulatory for me to put you in a secure setting. At the big reveal, I asked, after 3 months of these people meeting, how are you going to do that? Because I can put you in a nursing home in the memory care unit. I can put you in a jail or a prison or a psychiatric facility. And the response was we didn't get into the weeds. This was 3 months, included attorneys. This is question number 1. I am so glad that you pushed on the Ash campus because the conversations right now are a diversion facility, which is very important and must include involuntary. And there is space on that campus to do that, and we should consider it. But we have a long-term population living at the state hospital and in our jails and our streets, and they need the rest of that campus to be an intentional community, and the staff at ASH at every level, and I practically live there, have not been included in any of these conversations, as they were not in our $300 million plus redesign of a new state hospital here in Travis County that has fewer beds, no step down, and nothing for the children. So we have people right now who are sitting in our jail, and they have been on the highest level of care under Integral Care's auspices, ACT, AOT, FACT. Have we now decided that we will only work within our framework? And if none of that worked, I am leaving you to the jails or the streets. I have put this forward multiple times, and when I write emails, everybody's on it. And I do it on purpose because nobody gets to say I didn't know. Okay, I'm gonna try to wrap this up. Daniel Cummins is sitting in your jail right now. Robert Daniel Cummins, he's been on everything. So answer the question because he is being left to the streets and the jails. We had Robert Munguia die in our jail just very recently. He also cycled through highest levels of care, and he was arrested from Yvette McKinney's place. And I recommend all of you all go and look at where the highest level of care individuals go because they've exhausted everything else. Nobody will take them, and they're sitting over there in between airport and I-35 by the In-N-Out, and it is unbelievable, and she's already gone to prison. But one data point that you all need to really look at is under Medicare. I am so sick I qualify for Medicaid. Now I qualify for Medicare, and Medicare has a lifetime limit of 190 days of inpatient psychiatric care. Nobody's collecting this data. How many people are sitting in your jail, homeless, going through your emergency detentions, and we have identified them as highest needs and left them unfunded.
Thank you very much. I really, and I think we all appreciate very much the passion and the work that you've put into this. And we will continue to have conversations and welcome you to send us information. So thank you for coming today.
Yes, and I'm happy, if anybody wants to give me your email, I'm happy to forward you emails so you have a much clearer understanding of these issues.
Thank you.
And they're listed on our website. Yes.
Okay, Yesenia, who do we have next?
Yes, thank you so much, Sonia. Up next, we have Brandon Wallerson, who's here in person with us.
Good afternoon. My name is Brandon Willerson. I'm here today to offer a mission moment spotlighting the work of Central Health's Health Equity Policy Council, or CHEP Council for short, and our recent Healthcare Equality Index initiative, of which we have a lot to be proud of. I currently serve as a Senior Director of Philanthropy and Community Engagement at Vivint Health, a local and multi-state provider of integrated HIV care and prevention services. I'm also a social worker and have served in numerous HIV and LGBTQIA-focused organizations for the majority of my career. For the past 7 years, I've served as a member of the CHEP Council, working on such initiatives as our HIV screening initiative, which increased routine HIV screening in area hospitals and safety net clinics, our Pandemic Equity Committee, and for the past 4 years with the Healthcare Quality Index initiative. For those of you who aren't familiar with the HEI Index, it's a biannual national benchmarking tool developed by the Human Rights Campaign, the leading national LGBTQ advocacy organization. This tool evaluates healthcare facilities' policies and practices related to the equity and inclusion of their LGBTQ plus patients, visitors, and employees. In 2024, HRC evaluated nearly 2,400 healthcare facilities nationwide. But I'm not here to talk about all of those. I'm here to talk about the 5 that we are so glad to bring into the family. And in 2024, just recently, we have 5 local clinics and community sites that have received the 2024 HEI designation. These clinics include Vivint Health, People's Community Clinic, Austin Public Health Sexual Health Clinic, and the two new entries to the HEI ecosystem are Integral Care and Community Care. I see we have leaders from Integral Care here with us, so huge shout out to you all and the amazing staff. Over these last several years, CHEP Council's HEI committee has worked closely with a cohort of amazing leaders across these organizations, building community resource tools, and a shared understanding and commitment to better serve our LGBTQIA patients and clients, while also ensuring that our workplaces are welcoming and affirming to our LGBTQIA staff. With these 5 designated clinic and community partners serving over 100,000 patients and clients in Austin and Travis County, we show the rest of the state and indeed the nation that Austin is committed to creating a more equitable and inclusive care environment for all. This work would not be possible without the dedicated leadership and support of the staff at our cohort partners, but also wanted to highlight the leadership and support of Central Health in every aspect of these last 4 years. We would not be positioned in a way to advance this initiative in the way that we have without your support. I'm so grateful for this opportunity to share this important milestone with you, and I look forward to our continued work on the CHEP Council as we deliver on Central Health's mission in our community. Thank you.
Thank you very much.
Thank you, Brandon. And up next, last but not least, we have Kent Kaziski.
Hello, Board of Managers. Again, I'm Kent Kaziski, the Enterprise Manager of Diversity, Equity, Inclusion here at our organization. I'm happy to be representing the DEI Council and DEI team again, but before I get into it, I just want to also recognize and highlight that we are planning to coordinate more diverse voices coming from our DEI Council to show up the rest of the year as we kind of gain them more involved. Before I get into our major recognitions, I also want to highlight that June is a very busy month for us all. It's Men's Health Month, Alzheimer's and Brain Awareness Month, PTSD Awareness Month, and many more. And I want to highlight our wellness and communication partners who are doing a great job recognizing and building the thread between all these months into our recognitions. Specifically, this month, the DEI Council is happy to focus on Juneteenth and Pride Month. Juneteenth, also known as Freedom Day or Emancipation Day, became a national holiday for us in 2021, but here in Texas, it has roots going back to 1938, where we've been celebrating as a state. Over the years, Central Health has participated in Juneteenth in the marches, provided education on the history and background of this holiday, and it's no differently happening this year. Internally, we're promoting multiple community events occurring this weekend, including a Black Makers Market and a Black Queer Open Mic, while also expanding the voices of how individuals have learned and are still educating about this holiday in our employee networks. All employees are going to be invited to participate and learn more over this next week as we lead up to the holiday next Wednesday. June is also LGBTQIA Pride Month, as y'all have heard, and our internal theme this year is decoding LGBTQIA awareness, strengthening our support for the community. We've launched a month-long initiative for our employees to deepen their understanding of how to support LGBTQIA community members through self-exploration, learning, and active participation, where we're highlighting topics internally and externally around learnings and articles, community highlights, and about really critical, innovative, and business updates, such as the HEI initiative, and making sure all of our employees understand the process and the story that went into the HEI the last 2 years. So we are really committed to this month, but I also want to highlight that we're also continuing these efforts throughout the entire summer. We will continue to share updates about the HEI initiative to cap it off with the celebration with our community care sexual health team at Austin Pride on August 10th. And we're really excited to continue this education information for our employees over the next 2 months. So we look forward to sharing these initiatives with you all throughout the rest of this year. And I also want to highlight, if there's ever any other input or advice you all would like to bring to our employee population, please let us know. We're a conduit to that. We really want to make sure we're highlighting and recognizing all these voices in our employee population. So thank you.
Thank you. Yesenia, is that everyone?
Yes, this concludes public communication and mission moments.
Okay.
Thank you.
Okay, I've consulted with our budget chair, and we're gonna have a 10-minute break. That means no more than 10 minutes. So we're gonna gavel in again at 6:10. So, okay, thank you. To stay in our Board of Managers meeting so we can get the first part taken over, or taken up. Okay, so I'm going to call to order the meeting of our Board of Managers at 6:11. The first item on the agenda is the consent agenda. And do I have a motion for the 3 items on the consent agenda? So moved from Manager Zamora, second from Manager Martin. All in favor? Say aye. Okay. Now we're going to move on to our item number 2, which is the receive an annual update from Integral Care. So Jeff Richardson and Trish Young Brown will be presenting.
Ready to get started?
Yes. Is everybody ready?
We are.
Okay.
Feels so much better in here than it does out there. Just let you know. Perfect temperature. It's great to see everyone. Thanks for having Jeff and I here to represent Integral Care. I'm Trish Young Brown. I'm the board chair for Integral Care. Am I in my 2nd or 3rd year? I think I'm in my 3rd year. It's going so well. Time doesn't matter. And the reason why it's going so well right now is we have a new CEO, Jeff Richardson. And it's really exciting to be able to introduce him to you all tonight. We do have a presentation that Jeff is going to give. I'm here to answer any questions if you want to probe down there a little bit. Hi, Cynthia. And I just wanted to mention that Jeff's been here, 2 months now?
This is my 49th day.
He's not counting. But he literally just physically moved. The moving truck showed up this morning, so he's here. He's not going anywhere. He's stuck. Our transition has been wonderful. Dr. Lee has been so gracious to both me and to Jeff.
More to you, though.
Well, I don't know what happens in your conversation, so I'll leave it there. But just really helping Jeff get oriented, not only to Central Health, but what's going on in the community. And we are really excited about the conversations that we're having. And for me, it really exemplifies what I discussed with this board the committee last fall when we were discussing my reappointment, how we wanted our relationship to be more integrated. And I really feel like the opportunity with Jeff coming on and Dr. Lee coming on at roughly the same time, it's given us kind of a fresh perspective on how we can work together. And I'm really pleased to be able to say that I and the board feel really, really encouraged by the stronger collaboration that we have. It's more than just a discussion about money and how to make things happen, but like what should happen, not just how to make it happen. So really excited about that, and I'm going to turn it over to Jeff. I know we have a presentation, it's long, but you're just going to hit some highlights, I think.
Yeah, and I heard we had about 4 hours to complete this.
5 or 6, but no.
Give or take.
You can be here by yourself. We'll be leaving, but that's okay.
Fabulous. We do have a lot of slides, but a lot of the slides are going to be more referential than, I'm not going to torture all of you with all the detail in each of the slides, but there's some good information there, so I hope all of you get a chance to look at it. If you could switch to the next slide, please. And while we're doing this, if there's anything along the way, if you want to ask me a question, feel free to do so. And I know at the end we want to do
Jeff,
questions.
why don't you take just 10 seconds or so, or maybe a minute, and give the folks your background. I'm not sure that everybody is aware of your background.
Absolutely. I'm a Sagittarius. My background, I'm actually been in behavioral health services for about 37 years. My background, I'm a social worker, been a clinical therapist, run a number of different behavioral health programs in Maryland. My most recent job was the chief operating officer at a place called Shepherd Pratt, which is the largest nonprofit behavioral health provider in the country. And so my work there was very involved in really building out over the past probably 25 years community-based services in and around Maryland and in other states. And so I was so excited for the opportunity to come here to Austin. I have family here, and I was more energized about the notion of really working on community-based services. So, my experience also is very personal. I have a son who's autistic and mentally ill. I have family members who struggle with getting the support and care that they need. So not just services, but access really matters to me. And where I came from, partnerships is what drove our ability to do the good work that we did. And, I was so excited to build that partnership with Central Health and Dr. Lee. I was joking before, Pat has been mostly nice to me most of the time. And we've really had some great opportunities to work together. So I'm very excited to be here and very focused on what we can do to build on the great work that David Evans did here as CEO and really expand on it. There's so much opportunity here in Austin to build on what we need to do. So really what I'm going to do today is sort of give some overview, and I'll go over it fairly quickly, but also, really want to get sort of the notion of our partnership and what we can do with each other down and emphasize some areas that I think really are important to focus in on. Much like Dr. Lee, I'm here, I'm here for 50 days. By my 100th day, I think we'll have solved all of this and come up with a really cool PowerPoint to share all the next steps. We have a lot of work to do. And we have some of our integral care team here who've been just fantastic to work with. Dawn and Kathleen, thank you for being here too. Appreciate it. So next slide, please. Next slide, please. I'm only going to touch on this, but many of you know enough about integral care. But we have been around since 1967, and our focus has been supporting the health and well-being of adults and children living with mental illness, substance use, and intellectual and developmental disabilities. Those are the areas of focus that we've been started for and continue to build and grow on. And again, this was one of the first community centers to really do some of the work with community behavioral health and intellectual disabilities in Central Texas. So we sort of laid the groundwork for a lot of other parts of Texas, and very excited to see us continue to do that. We also, all those little insignias at the bottom, we have a number of accreditations that include that you can look at on your own, but we have been nationally certified in a number of areas, and that is not easy to do, and this team has been very dedicated to making that happen. Next slide. So I want to slow down on this one for a second and just kind of lay this out in the impact that we have here in Travis County specifically. Right now, the numbers are looking at that 1 in 5 people will be diagnosed with some type of mental illness in their lifetime. Actually, some of the data now is looking at 1 in 4. So because of what we went through in COVID and really what's happening now, that's a significant number of people in our community that need help. I think right now, what are we at, about 1.3 million folks here in Travis County? So we're talking about close to 250 million people, or 250,000 million, no, not yet, but really who are needing, could need behavioral health services. And of that, probably half of those are folks that may have public coverage through their private insurance and other means. And we served last year close to 30,000. This year we're going to drive even more folks, but that we're only touching the tip of the iceberg in terms of services. We have an enormous amount of work here and across this country to make sure access to behavioral health services is there. And again, when we look at this, nearly half of all these mental illnesses start before the age of 14. 1 in 6 children have 1 or more developmental disabilities or other developmental delays. And one of the things that's happened during COVID, if you had one of those developmental delays, it was particularly challenging. And we're seeing some of the evidence of that with the work that we're doing in schools here. We're seeing a lot of kids really struggling. And as we get more sophisticated about diagnostic efforts, we're also seeing folks on the autism spectrum really presenting more and more with, and frankly, not the sufficient access to meet all of their needs. And then one of the things that's been striking in 2000, 22, and actually this year, we're continuing to see the uptick in opioid deaths in Travis County. It's made the news. Fentanyl poisoning has continued to grow as an issue. Addictions, not just opioid addictions, but alcohol abuse and a number of other challenges got worse during COVID and continued to linger thereafter. We have a lot more work to do to actually reach those folks in our community. Next slide. And so again, just to reinforce this, we at Integral Care support adults and children living with mental illness, substance use disorder, and intellectual developmental disabilities. We have many folks that we serve who don't fit into a neat box. It's not one thing or the other, but are experiencing all of the above and are struggling with that. And the type of services that we do really are catering not just to that one diagnosis need, but all the needs of that individual. Next slide. So it's hard to put on one bulleted sheet all the different things that we do. Someone asked me what it was like to work at Integral Care and what were all the services. And I said, did you see the movie Shrek? And when Shrek talked about ogres are like onions, you just have to unpeel them layer after layer. And Don actually mentioned to me it's going to take me years to get truly the deep understanding of what we do. But there's a deep appreciation for the depth of services that we do. And when we talk about behavioral health services, it's not one thing. It's a series of services where people are in their own recovery and what needs that they have at any given point in time. From people with severe needs to people who are doing well, who need supports, to people who this may be their first experience with a mental health or behavioral health need. So some of the things that we do that are pretty straightforward, we do care coordination. One of the things that's really difficult in healthcare in general, and behavioral health it's even worse, is navigating the systems that we offer. We throw around acronyms, our insurance companies make it confusing, our payers challenge us. There is so much we have to do to make it easier for people to access care. Our team does an enormous amount of work really connecting the dots for people on services, how to access them, and how to coordinate amongst other providers. And again, one of the exciting things about the partnership with Central Health is really what we can start to do to look at sharing information, data. One of the things Dr. Lee and I have talked quite a bit about is how do we create a way that we can access information to make it less painful for our patients and our consumers, our families, but also for our treating clinicians. How can we make a more even flow of data and information? A 24/7 crisis response, I'll talk about that in a little bit, but we do a number of things to provide crisis services to folks. Everything from 988 to mobile treatment services, mobile crisis services, to work with 911, to residential crisis, to walk-in services at all of our clinics if somebody is in crisis. And so that's a really important tool in our toolkit to help people get care. Because when people are in their worst, is usually an opportunity to help people get the services that they need. Integrated behavioral health, again, when we start talking about behavioral health, it's integrating it with other services that we do. Everything from primary care services and collaborative care work that we do, to coordinating it with residential services, with other partners, with some of our partners that have very special services, and really making sure that we can link the behavioral health needs of that individual. And again, one of the things when we start talking about behavioral health is, it's striking when we look at the data on overall costs for people who have behavioral health needs and overall medical spend. So typically 5% of the folks for example, in Medicaid, usually are about 50% of the total cost of Medicaid. And the vast majority of those folks in that 5% are folks with pretty significant behavioral health needs, many of which are untreated. If untreated, it exacerbates all the other conditions that that individual is struggling with, from being unhoused, to be medically fragile, to being in and out of emergency rooms, jails, all the things that we've all talked about. So providing that access early and often is really key. And having that access and not just to do it in one place, but opening up at scale. So residential services, we've talked, in this city, there's been a lot of discussion about homelessness specifically, but housing is a full continuum. And Sonia, I heard you talk when we came in, there's some very intensive needs and services to folks that prevent someone from actually being homeless. All along that continuum, And one of the things that we do along with providing housing is actually providing the support component, being able to ensure that people get the supports that they need. And we are on a long journey to continue to expand the access to services. Of the nearly, right now, I think it's about 13,000 adults that we serve, almost 90% of those folks are at risk of being homeless. And so, and we're in a city that's growing rapidly, and the cost of living here is growing rapidly. We have a lot of work to do to make sure that we can provide treatment and that housing to meet those needs. And so when we talk about just homelessness and housing services, it really matters to be able to provide services where somebody is in their own recovery, based on their individual needs, from someone who simply needs support to prevent someone being homeless, to providing very intensive treatment services, to provide crisis in high intensive services. That whole continuum is needed, not one or the other, but all of it. And one of the things that's been really a great partnership is working with Central Health on our jail diversion pilot that we're doing right now, and really being able to expand the coverage of 24/7 clinician support. That's been really, really key, so that when people walk in, they can get that intervention when and how they want it, not when we can deliver it. And so much of healthcare really has been switching and pivoting, because if we don't do it that way, we're going to continue to not connect with a large group of folks that we care and desperately need our services. And we'll end up in jail needlessly, and in other places needlessly, without the supports. So other than that, we've talked about jail diversion. Along with the jail diversion project we've talked about, we're also doing a lot of work also to prevent and divert people from ever going to jail. And that work is critically important, as well as people who've been in jail, making sure that they have access to the services that they need treatment-wise to help them not have to return to jail. Not just here in Travis County, but across the country, some of the largest treatment facilities in this country are not hospitals, but they're jails. For many years, and Trish, I know you're from Chicago, so don't get, but in Chicago, in particular, the jail system there in Cook County is the largest treatment facility in the country. And so, and what that's telling us is that we're not actually treating people where they need to. We're finding ways that people actually can get arrested to get care. And that's not necessarily the most efficient way to use anybody's time. And when we talk about substance use, one of the things that we've done, we have everything from medically assisted treatment, where someone's struggling with an opioid addiction, our methadone treatment services, our Suboxone programs, but also the education work we do. And many of the folks that we treat, in fact, statistically, is about 60 to almost 70% of those with a significant mental illness also are struggling with some kind of addictive disorder. And with that, we not only when we treat that individual for their addiction needs, we're also providing treatment services as well. And the last thing on this list, is the last thing, but it's always the first thing. What are we doing for preventive care? How are we ensuring that people have the mental health supports that they and their families need? We've done a lot of work with, and many of you have heard of mental health first aid, but other services to at least get people to know if someone's struggling, what they can do to get support. A lot of education and training, but I think we've only touched on the tip of the iceberg. Next slide, please. Am I talking to a robot, or is there a human switching the slides? Okay, thank you. So the other thing that we do, as long as being a provider, one of the other roles that we have at Integral Care is as a local mental health and IDD authority. And what that means is that that's simply not being a provider, but we also have some responsibility for ensuring a network of care and services continue to happen. One of which is utilization management. We work with our partner providers to ensure that they're delivering on the services that someone needs and managing those effectively. The quality of the services being delivered, not just by those folks, but by our team as well. Also being a link, if services aren't going well with one of those providers, is that we have team members that also work to ensure satisfaction of those consumers. The other thing that as this community grows, we need to continue to expand our network and doing network development, credentialing and management. And then part of what drives that overall strategy is our local plan. So what are the services that are needed in this community, and really developing a local network plan as well. So this simply isn't all the things that we could do as an organization, but what our partners can do as well. And then again, we talked earlier, but one of the things we do a lot is train a lot of our provider partners, providing them with a lot of the support and trainings to provide evidence-based care as much as needed and as much as appropriate. Next slide, please. So this is really small. So but again, we have 3 sponsoring agencies. Our favorite, and don't tell the other guys, is Central Health. But this makes up, our total budget is a little under 150 million. And, we do have support from Central Health, from the city and the county, but we also have a number of grants and other payers as well. Next slide. And so I just want to touch on this just so the work that our team does daily to make all of this go in the right direction. We have 200 funding contracts, but we have nearly 400 sources of funding for what we do.
40 different sources.
Oh, that's just for the grants, the contracts. We have 400 in total sources. So, yeah.
Okay. That's a new statistic. They've never presented it that way. Wow. Okay, so my head just went.
So, and 60% of that funding comes from grants. And, one of the things that, I'm a social worker, but I have an MBA. So the MBA sometimes says, wait a minute, Jeff, 60% of our funding comes from grants. We never get indexed against inflation. How do we financially make this work? And so how do we keep up with the service demand? How do we keep up with staffing? How do we give people the wages they deserve to do the good work that we're doing? We have an enormous amount of things that we do that we need to continue to find other sources of fund simply to keep going, not just expand. And we need to do both. Next slide. I'm not even going to, this is way too small for any of you to read. But one of the things that Texas did very creatively is to work with federal partners or across the U.S. and particularly the federal government to come up with something called a Certified Community Behavioral Health Center. It's a way to leverage federal dollars, but in return for that is a requirement to provide a set of services with a set of outcomes that meet not just a local standard, but a national standard of care. So providers across the country would meet that same level. And here, really what it's done since 2016 when it was rolled out, we've been able to expand nearly 40% more services to people than we were before that. So again, when we talk about access and expansion, that's really one of the key things that we've done. And it's allowed us to add over 100 new positions and really ways that really help us, what we've talked about earlier. How do we connect programs and services together in a way that's helpful? How do we do in-reach? How do we work with jails? How do we do more coordinated medical services with our partners? All of these things are key to helping someone recover. Next slide. So I feel like I should be like one of those NASCAR drivers and we'll have all of our different partners that we have. We've got a lot of partners. This isn't all of them, but these are ones that we put on for this slide. The partnership and the work that we do with everyone in this community is really critical. This is a community that is both big and small at the same time. And we need to be able to make sure that we connect with everyone. And for me, this has been part of the work that I've done in my first 50 days here. Next slide. Our services, next slide. So this is data from last 2023. We're finishing up 2024 now, but I can tell you all of these are more. It's a fancy high-tech statistical term. More of all of these. We're serving more residents. We're providing more services. We have more staff, and we have expanded our programs and services. And we need to do more. But again, it's noteworthy to know that as we talked earlier about the number of people who are struggling with mental health in their lifetime, how small that number is. We have a lot of work to do. Next slide. So really, when we talk about our approach to this work, there's a lot we do around being person-centered, trauma-informed, culturally competent, linguistically appropriate, and integrated and collaborative. Because of the fact of the matter is that we can't do all the good work we want to do by ourselves. It's not just a good idea, but we desperately need to do it that way. And this community has a long-standing, great commitment to partnering and coordinating with each other. Next slide, please. Not going to go over this slide, too small. We'll go through it later. And this one too, but I want you guys to look at those when you get a chance. It gives you some examples about how people use our programs and services. But there's so many important pieces of that wheel and that pizza that you just saw that really help someone deliver care. And I said earlier, it's so important to think about, it's not one service at one time that somebody gets from Integral Care. Behavioral health services, and particularly folks struggling with long-term chronic and persistent mental illness, there is a number of things that happen, and sometimes we treat people with addictions and mental health services as a one-off success or failure. But we should treat it more like diabetes, where you don't expect to be treated with diabetes once and hope everything works out. This is long-term services that we need to provide in a variety of different settings and conditions to help someone be successful. And so where we serve people, and those of you don't look at that screen, but here you can get a sense of it, is the vast majority of people, the numbers of services that are in our clinics, also, in our call center are really, we take a lot of calls, and if we have time, if we don't, if you wake up at 3 in the morning and you can't sleep and you want to get some inspiration, there's a video embedded in this about our call center, which is fascinating. And you can see some of the remarkable successes that our staff have and are doing as we speak to prevent people from needing more intensive services and linking them to care. We also provide a lot in someone's community and other healthcare facilities, in schools, and the criminal justice setting. And I suspect where we're going to see a couple areas of trends of growth for us have going to be in the criminal justice settings, because again, that's an area where people need us most, and in our schools, because there's a huge demand for the schools for added supports. The past couple of years have been really a challenge, and so as we look at expansion, these are some critical areas that we need to look at. Also in housing and residential, we have really only scratched the tip of the iceberg, scratched the surface of that iceberg, for the amount of housing that we need to deliver for people in this community with support services. Next slide. So just to give you a sense that this is where some of our clinics are and our psychiatric emergency services are, but we are spread out even at these locations, which are throughout Austin and Travis County. Our staff are going everywhere. They're on the road. They have people working 24/7. 365 days a year. And as I know I've repeated myself, but we're not doing enough. There's more we need to do, and we need to do a lot more expansion to meet the demand. Next slide. So when we start breaking down the different age ranges of folks that we serve, again, when we start looking at what we do for adults, we do everything from traditional outpatient therapy to psychiatric services to drug and alcohol treatment. Housing, and again, as we talked earlier, in a variety of different settings, from supportive to residential crisis to prevention of homelessness. All of those are key to be able to provide that success for adults. And again, we're serving adults who may have a variety of different needs. We're working with a number of folks with different needs, along with developmental disabilities. We're working with veterans. We're working with folks with significant co-occurring addiction needs. All of those require special interventions to help someone maintain their success. And when you talk about healthcare, housing is healthcare. And if we're not providing that, we could have the best therapists and psychiatrists in the world, but if we can't provide basic needs that people need to be successful, housing, a job, friends, a sense of community, we're going to fail people. Next slide. So this is just the numbers. This is where we were last year. But again, we served about 13,000 adults. Of that, 6,000 of those received supported housing services. 536 received medical assisted treatment. That's ongoing methadone treatment that people would get on an ongoing basis through our outpatient services. And 410 is the clients who receive supported employment services. And this is an area that I also really want to tackle here is I think when we can help people get a job, we provide meaning, and we can help do a lot of medical interventions when someone feels passion and energy for the work that they do. Next slide. So when we talk about children, we have done a lot of work in both our clinics, but also in our schools, and we also do a lot of work with families. So when we're talking about the services to children, it is not in one location, and we're frankly seeing a lot more kids and their families struggling to meet the needs of their family members. Next slide. So we served about a little under 5,000 kids last year in our overall in our children's services. About 1,100 of those we served in schools, and we provided services in 35 schools across Travis County. And again, I suspect we could double or triple that and still wouldn't meet the need. Next slide. So the other thing that's really, the team here has done an enormous job about building is the crisis response system that we have. We have a helpline, and again, if anybody here calls 988, we're actually providing 988 services not just here in Travis County, but for 52 counties across Texas through our call center, which is, and really being able to route people locally to the services that they need. But, there's some amazing stories about how we've helped people get the services they need and provide the intervention, but also really understanding what services are out there, because this is a black box when it's trying to figure out what and how to get the care that somebody needs. Not everyone has strong advocates or an understanding about what is out there in our communities for folks. And I think a lot of the work that we've been working on as an organization is some zero suicide initiatives to work with families, work with schools. You've heard me mention earlier mental health first aid. I would love to do a training for all of you. It's a great training if you ever get a chance to do it. It's one that also can help you help others identify how to get help and what's the best way to do it. And it's not boring, it's fun, and it actually goes pretty quickly. And then, one of the things that with our teams, we're not only waiting on a phone, our teams are working with the police department through 911, and we're also doing work, our mobile crisis team, our MCOT team is out providing those services. But what I'll say that's noteworthy is that we're doing a lot, but I would love to see us do a lot more in terms of access and care for people in this community. And then you go to an urgent care center, we also have walk-in capacity at our crisis center, but also in our clinics themselves. We've gone to a new model of scheduling. So if somebody wants to see someone, we actually can get someone to see a clinician very rapidly. We've gone away from the old model where you'd have to wait 6 months for an appointment. People can walk in, or our team can schedule them online. Next slide. So again, when we talk about calls, we nearly took 83,000 calls last year, and that number is rapidly expanding beyond that number this year, and provided emergency care to adults and children at our psychiatric emergency services. And again, I want to thank Central Health because now we've been able to provide 24/7 coverage in that center thanks to the support there, and that is critical. Not everyone can schedule their emergencies between 9 and 5. So the great news about our 911, and actually we have there's a lot of great data behind this, but we were able to divert nearly 86% of the calls when someone called 911 through our mental health services, and really had some great outcomes because of that. That system is also really overburdened right now, and so anything we can do to get the care that people need when they need it is fabulous. Our MCOT team, which is one of our emergency crisis team that gets linked to the 988 team, served nearly 3,500 people, and that plus our crisis outreach team, that's a large number of people that we're reaching with that. And again, those services really prevent someone from getting arrested, but also waiting needlessly in emergency rooms and other places. Next slide, please. So this just gives you the trend line. We expect this year we're going to far exceed that 83,000 number. It's not an aspirational goal to keep, but it's a reality that we're in, that we're dealing with more people in crisis than ever before. Next slide. So the other thing that we haven't spent a lot of time talking about, but we are also the IDD authority and linking a lot of providers through our developmental disability services. We're helping people in Travis County live independently, have access to stable jobs, providing employment services and navigation to care, helping people create partnerships and friendships, and really, again, linking it to our crisis programs. Next slide. So we provided nearly 50,000 services and to nearly 2,700 people through our programs and our partners. And again, when we do that, this is a group of folks that, again, are struggling maybe not only with a developmental disability, but may also have a mental health need as well. And again, having that ability to serve all of the needs of that individual at once are key. And so one of the things that we're looking to do is how do we provide more specialized care for these unique populations of folk. Next slide. This again is a small slide with a lot of little things on it. We provide a lot of training to folks, both in our own system. I mentioned mental health first aid. We also have done a lot to work with our individual consumers on smoking cessation. First responders in our community, we've done a lot of mental health first aid trainings and specific interventional trainings to help them handle the difficult experiences that they have to work with. We're doing a lot more suicide and disaster support for folks that have experienced a family member or a death by suicide. And then a lot more suicide trainings. And this is an area that we will continue to grow and expand into. Next slide. Who we serve. Next slide. This is really just a breakdown of the overall populations. Right now, in Travis County, and I don't think these numbers are going to change much in fiscal year 24, but about 38% are white non-Hispanic, 36% Hispanic or Latino, 22% African American, 2% Asian, and this, of course, the other category that exists. But I think that this, one of the things that we've seen is, next slide, please, is that we also have been very dedicated to providing other language supports for people and culturally appropriate work. We talked earlier in the meeting, I heard discussion around DEI initiatives. We've done a lot to work with not just with our staff, but also our clinical interventions to be more reflective of the people that we serve. Right now, most of the people we're serving are between the ages of 25 and 55, but I see that trend moving in the direction of younger folks and continuing to go in that direction. Next slide. So this is a heat map that essentially says where most of the folks that we're caring for live. And again, it's really along the I-35 corridor, and it's increasingly around North Austin and the Southeast Austin area. And as you guys probably have talked about in your meetings, one of the things that's happening, the affordability in our community for folks to get care and services continues to change the heat map about where we're providing services and where people are living, and we have to respond in kind. Next slide. Oh, no one's going to be able to read that. Next slide. The only thing about diagnoses that you should probably be aware of is that diagnoses are not always the best indicator of the overall treatment needs that someone gets. We have a lot of folks that may have a label that doesn't truly reflect both their ability to recover, but also the other needs that they have. And so we've mentioned very briefly, but when someone comes into integral care, they may be coming into one of our clinics for treatment. They may be getting help finding a job. They may be getting housing support. We may be working with their family members, and we may be linking with our partners in primary care and other housing providers as well. There is a thick, rich connections that we have in terms of providing the services that we do. I am not going to go through these because I know I don't have much time left. So, but please, these are some great stories of successes, and there's a video attached to one of those. If you skip to the next slide, please. Next slide. Next slide. Next slide. Next slide. Again, I want to leave you guys, other than you guys have a very long meeting scheduled today, but I wanted you to hear from us about how excited we are to collaborate and partner with Central Health. We can't do it alone. We desperately need to work with our partners. And I'm really excited that we've been able to forge a good relationship with, not just at the executive level, but within our other team members. And so, there's more work to be done with that. I think the reality is the demands for this services are so significant. And, one of the things that I've done as my career is building out community services, is that this community is ready for this, but we really need everyone's support to make it happen. Next slide. So when we start talking about alignment, again, integration of care, we've talked a little bit about equity, but making sure that both access to care it reflects our community, and that we can reach everybody who needs these services in a way that they need and want it. We can't understate the value of navigation of these services. It is so hard to figure out both where to get services, how to get them, also working with our partners in the community and advocates to really look at how we can further expand services in an area that are most meaningful. We talked a little bit about the diversion work, but that is a significant issue here in Texas because, frankly, there's been a lot more work we have to do around access. So if the best place for people to go is to get arrested, to get care, we got a lot of work to do. And then, again, a lot of system planning with you all and all of our partners to continue to grow and develop this system. So thanks for your time. You guys have a long meeting schedule, and I'm like right in the middle. I'm grateful at least you got to eat something first before you heard me talk. Thank you. I'm really excited to work with all of you.
Thank you, Jeff, and thank you, Trish. I'm going to give us about, so I think we have until about 7 or 8 minutes if people want to ask you questions or would like to say anything. First off, I believe what you just presented is in our backup.
Yes.
So, and perhaps we should also send it out electronically so that people can get the links that you talked about. So we'll make sure and do that. It's in the backup for the Board of Managers meeting. You may be looking in the wrong one. So, so we'll do that. So I'm going to start on this side of the room and just go around and see if anybody wants to say anything. We'll start with Manager May.
Thank you. Good to see you, Trish. Hi, Eliza. Good to see you, Trish. And obviously, Jeff, welcome to Austin and the work that is ahead of you here. My name's Elisa May. I'm a brand new manager here. But I used to serve on the MHMR board back in the day.
Okay.
Yeah, so I'm rather familiar. I know it's changed a lot. Obviously, new name, new everything. But I did serve under Dave Evans. That being said, earlier we had a question as part of our goals and part of our own workings that we're going to be doing or attempting to do with our body here. And it included some possible collaboration with ASH, the state hospital. Austin State Hospital. So here's my question to you, because I think it's the timeliness is appropriate. What is the role that you have with ASH, and at what point does your population that you serve intersect with ASH?
Well, to answer your last question first, is that the folks that we serve now with behavioral health needs are at ASH. And our goal is to make sure that when people are ready to leave, that we can provide whatever supports that they need. So I know there way before I got here 50 days ago, there was a lot of planning about what the intention was to build and develop on the ASH campus. I think we're very early in discussions about what and how that could look. What are the practical ways that we can get something done? But I think, as you heard earlier, there's an enormous amount of need for services along that full continuum of care, and we've just started to marinate those conversations. But I think, to answer your question, if someone has a behavioral health need and is at ASH, those are our people, and we need to figure out how to support them.
Yeah. Thank you.
Yes, quickly, thanks very much. Good seeing you again, Trish, and welcome to Austin. I used to live in Baltimore, so I'm Maryland.
Is that an Oriole shirt you have on?
No. I noticed in your presentation you spoke a lot about youth, and particularly as a result of the pandemic. One of the things, at least from the public health perspective outside of our community, of the population that we service, is a large number of seniors who have been significantly impacted in terms of mental health issues. Are there things that you're doing that are working to address the mental health of seniors, both in the population that we serve, but also maybe collaboratively with others in other? And then the other quick question is, your heat map here, what we've seen over the last 10, 15 years is the growth in the eastern, what we call the Eastern Crescent also. So I'm not sure if you've had the opportunity to see what kind of services and extend services out beyond to the Eastern Crescent of Travis County.
Yeah, I mean, I think that the great question. That first, we've been looking a lot about where we're serving people, and again, thinking through what's the best ways to reach them. I think your question around seniors and people in our aging population, depression is so significant in that population, it goes untreated. One of the things that we're doing now, and our Amanda Banks, who's our equity officer, has done a lot of work with, is really looking at partnerships with churches in particular, because me showing up and pitching you should be getting mental health services to a senior versus someone, their pastor or their someone that supports them, and also training people as trainers in the church to support seniors on what it means to access care and what that can be. I think there's a lot of people that probably end up in our primary care partnership because that's where a lot of this gets evidenced. My wife will complain that if I have a rough day at work, I start complaining about my back and my knees and everything else, and it tends to manifest rather than saying, I'm really stressed out. And so a lot of our seniors don't have the comfort level in accessing care, and we have to go where they feel most trusted. So the answer, we are treating folks, but we need to find more creative ways to reach them. And I think that's part of the work that's happening with our partnerships with Central Health and our FQHC partners, because a lot of people are coming in to primary care first and only but are evidencing pretty significant sleep disorder, depressive disorders, anxiety disorders that I think we can connect them with when they're in primary care.
Manager Ratwani, I don't know if you're on, if you can hear me and you want to ask a question. I don't know if he's on.
I can hear, and I don't have any questions.
Okay.
I've enjoyed the presentation, and I welcome Jeff, and happy to see him. I saw him in the lobby out here earlier. Thank you. Thank you, Chair.
Yes, we did.
Thank you.
I don't have any questions, but thank you for the presentation and welcome to Austin. Thank you.
Thank you.
Thank you and welcome. I had a question about funding. Is there any element to your budget that's more or less guaranteed yearly, or is it sort of a go begging every year kind of?
I will say that nothing is ever guaranteed, but we have some predictable funding sources, like we have grants that are more than a year, several years. We've also done a lot of work with the state in particular to work out a funding model based on the that CCBHC model I mentioned earlier. I think going forward, I think we have a good predictive way that we're working with the state on that. But I think it is a lot of work, frankly, for us to keep ahead of this. And so we're always monitoring our grants and looking to see where they may go. But as I said earlier, we have a lot of work that our team does to monitor those. But I think the predictable nature of funding is one that we need to keep battling for, because the people we serve, need us there not just for a couple of years of a grant, but for their lifetimes. Did you want to add something?
Yeah, if I could just add to that, I think it's just I appreciate the question, because it's sometimes it's not understood that even though Integral Care is a public organization, we are not a taxing entity. We have no established way to earn revenue or to receive funds. We have to collaborate with all the various funding sources both local, such as yourselves, the city and the county, state, and then federal, and some of our sources. So that is the nature of a mental health authority, is they have the responsibility, but they don't have the taxing authority that goes with it.
So, Mrs. Brown, do you think that would be a significant initiative to take forth to the county to become part of a taxing entity? Is that a possibility?
It's a really interesting question because it gets raised a lot in terms of what would be a path to that, what would be a source for that typically. If you look to some other states, you might see the use of a sales tax or maybe a special type of tax. And that would all, so I think the opportunity for us resides within what's possible in Texas. So it would be, oh my gosh, it would be fabulous in terms of creating a more baseline level of stability. It's a really difficult challenge.
I understand that.
Yeah.
I'm just wondering, I mean, to try and isolate mental health from everything else in healthcare is inane. And I would hope we can somehow move that forward as a group with you.
Yeah, and I really appreciate you bringing that up. I think all of our compatriots around the state would appreciate that conversation too.
And you know, I've done a lot of work in other states, and every state funding is different. But the reality is that there's never enough, and there's more to be done. Even if it's integrated, frankly, some of the services we've talked about are vitally, they're long-term care supports that are needed, that are expensive and need to be well financed and thought out. And I think there's a lot of work that we need to do to further expand that pie.
Thank you for your work.
Chair Kitchen, can I piggyback off that question?
Yes.
Thank you. I was curious about the foundation and, given challenges, especially associated with lack of funding and then uniquely restricted funding, do you have plans or is it part of a strategic initiative to build out, I guess, the relationship with the foundation? Or are there lessons perhaps to be learned, for example, with the Harris Center, I guess, foundation, or successes, or maybe lack of successes that might have occurred with other similar models around the state and the country?
Yeah, I think one of the things that we're actually going next week, and I've spent time talking to the other center directors across Texas, and frankly, even locally, there's a lot of variability. You mentioned Harris. I think they're struggling right now financially, and so we're doing better. And things need constant, deliberative, focused efforts. And I think, along with the work with our payers, you mentioned fundraising, and I think that's going to be a key part of our continued success. And I'm hoping all of us can be good ambassadors to looking at how we can support mental health services. And one of the arguments all along with healthcare in general is if we're able to provide these services, we can reduce the overall cost of services for everyone if we do it at the right time and get the right supports. So we don't have enough time tonight to go through financial models, but there's some that have worked really well. But right now in Texas, there's some challenges with looking at long-term funding with short-term strategies.
Thank you, Chair Kitchen.
Thank you. Manager Valadez.
Thank you very much. I've been a longtime supporter. My daughter's been on MHMR since she was probably 1. And we started in Dallas, MHMR, and then also with Dallas Services for the Visually Impaired. But she's integral care here. One of the big problems that we have seen in talking with other parents who have children, because she graduated from Rosedale, is that for those that are not English speaking, there appeared to be a problem, or not enough, of course, staff people to deal with the populations that don't speak the English language, and that was very difficult. Even though they're citizens, then you have to communicate with the parents, because the parents are the ones that you have to work with to educate and train to address that population, and also with the diagnosticians and with the teachers. They need major training, because you know, we have found kids that have gone all the way up through middle school having major MH issues, and they were never diagnosed appropriately.
Right.
Okay, and then they drop out of school and they end up in gangs and they end up dead, or abusers, and so I think that's a lot of work to do there. I personally look for alcohol and tobacco for being the sources of funding. You know, like a vice tax that would fund mental health and chronic illnesses in the state of Texas. I think that's it, because think about all the associated issues that come with alcohol use and then cigarette, especially if you're a pregnant mother and don't refrain. So that's just a suggestion. Additionally, a problem that I encountered throughout my daughter's and continue to encounter with my daughter is that your case managers, they change so often. We don't have I guess because they're your frontline defenders. You know, the people that we're dealing with at the front end of the agency, and oftentimes they're not there long enough. They just graduated from social work, they just graduated from somewhere, and they get hired. They're not getting paid very well. That's the way I think, only because there's such a turnaround, such a change in workforce that deals with our patients. And so it's very difficult to build a relationship with a case manager when you don't even know who the heck it is this week or this month. So that's just a suggestion. I'd love to have a conversation with you about it later on, looking at the process and see how that can be better handled. And also when you have transition gaps. Yeah. The transition gaps are significant for a parent, especially a parent who thinks that, my daughter or my child has been receiving services all these years that they've been in school, K through 12. And all of a sudden they're in the community, the parents have to work, there's no one, or the single mother has to work, or the grandmother has to work, and there's no one that can care for the child that has major issues. And so it's to expect that training or that education to occur in the school system is a joke. And so when you have an agency such as y'all's that is responsible for providing those support services to those patients, it isn't going to happen at that late in the game when the parents have or the person may have no resources. And so it's a systemic, almost set up to fail system. And the fact that you're only dealing with how many patients here in Travis County? When I was in the school system, I felt like there's a much greater need. That's why I'm saying there's an issue with diagnostician training and teacher training, so that they can early identify kids that are going to have access information or access health or access supports, or be specifically diagnosed so that they can get a BIP included into their ARD. So they're not there. You don't know how many times I went as an advocate for a parent whose child should have had a BIP, and there was never a BIP identified, never even thought to be even considered. And that's almost a rampant issue. And so as they progress through life, without having those supports, it becomes very, very difficult. Now they're young adult, and then they're going to be adult. And so I feel for you. I support you all with Integral Care. I support you all 100%. And I just wanted to let you know that anything you need from us to fight for you, we will. But there's got to be a different way, a different model that we can all come to an agreement about, so that we won't hear tragic stories or failed stories and hear more success stories. It's easy to see 1 and 2 every once in a while. You're going to see a success, but there's so many back here that aren't going to get to be the success stories. And
thank you, Manager
especially
Valadez.
in the poverty and non-English speaking population. Thank you.
Thank you, Manager Valadez. I'm sure that Mr. Richardson would enjoy spending some time, or would appreciate spending some time with you.
Can I just say hallelujah? I agree with what you're saying.
Yeah.
Well, but you know, I would just want to echo that last sentence. We do have a lot of successes, but there is a lot more work we have to do. Those both can live in the same space.
Thank you very much, sir.
Manager Zamora?
Jeff, welcome to Austin. And if you haven't heard me say this before, you're going to hear it for the first time. Our staff at Integral Care are all-stars. I truly, truly believe that. Your agency is a shining example of how healthcare should be done. And I've told the audience at the P&O committee that I chair that I go around to different meetings throughout the country, and we talk about healthcare and behavioral brain health, and I'll tell them about our MCAT team and how important that is for us, for jail diversion, and that y'all are doing the Lord's work, because y'all are doing the best care in the whole country. So thank you for coming. Thank you for coming to this committee, and welcome. Thank you.
Thank you all very much. I'm sure we'll have many more conversations in the future. Thank you.
Thank you for your time.
So, managers, we're going to continue now with the Board of Managers meeting because we have our attorneys with us to talk about the Birch lawsuit. So I believe the decision was made to do that next. I'm looking at Monica. Is that what we want to do? Okay. So we're going to go into closed session. Yes. Thank you. So, okay, David, what should we do at this point? Okay, it's recessed. It's recessed. Thank you. And we'll go back to it. Thank you for asking. Okay, so, thank you. We're going to continue with the Board of Managers meeting. Okay, so I announce that the board is convening in closed session to discuss agenda item number 5 under Texas Government Code 551.071, consultation with an attorney. And agenda item number 5 is receive and discuss a briefing regarding Birch et al. Versus Travis County Healthcare District, DBA Central Health, and Dr. Patrick Lee. So Monica Crowley will be presenting. So, managers, we're going to go into closed session now.
And then after that is the executive committee meeting. Chair. After that that's the executive committee meeting.
After, when we come back in, I'm gonna close out the board of managers meeting.
Right,
Then we're gonna go to the budget.
right.
Then, depending on what time it is, we'll come back to the executive.
But we will come back because that's the,
I know you wanted to
yeah.
speak about it, so we'll come back.
All right. Briefly though.
Yeah. Okay, so. We back and open? Okay. It is June 12th and the time is 7:35 and we are back in open session. So managers, I want to say this on the record. We are going to close out the Board of Managers meeting. Item number 2, we're going to defer, and that's the update on extending the MAP eligibility period. Item number 3, related to the process for the performance evaluation. We're going to seek input from the board members offline through, we'll be sending you an email, and you can talk directly with Jeannie Verdon and provide your feedback for her so that she can continue with her process. And that's the process for how we're going to do the evaluation. The evaluation won't occur until the fall. And then, let's see, item number 4, which relates to an update on the performance review. There is no update at this point, so we're not taking that up. And item number 6, that relates to the lawsuit with Central Health versus Ascension. There is no update on that one, so we are not taking that up either. Okay, so I'm ready for a motion. Well, item number 7 is to confirm the next regular board meeting date, time, and location. It's tentatively scheduled for Wednesday, July 24th at 4 p.m. As you may recall, we may be doing a special call meeting to work on the recommendations on the budget. So that may be July 17th instead of July 24th. So I would like a motion.
Chair,
Let's see. Yes.
and I'm really sorry. Is there if there were an agenda item I might like to present, would you prefer that I bring that to strategic planning in general, or I had something I wanted to run by and I didn't know if this might be a time for me to mention it.
Well,
or it's not even an item; it's just an idea.
Well, how about we mention it when we get to the executive committee? We have that schedule of meetings.
Yeah, the schedule. Okay,
Yeah,
that sounds good.
we'll talk about that.
Thank you.
Okay. All right, I'll take a motion for adjournment from Manager Musaitis, second from Manager Matwani. All in favor?
Aye.
Okay. All right. Turn it back to you.
Okay, well, good evening, members. I am going to resume the Budget and Finance Committee meeting. It is still June 12th, 2024, and it's 7:40 p.m. I will, moving forward with our budget, we are on agenda item number 3, receive and discuss a presentation on the proposed Central Health fiscal year 2025 budget and tax rate. Dr. Lee, Jeff Canodal, and John Morgan will be presenting. Members, in light of the time and where we're at, we're going to allow all the presenters to present. And we'll probably have a few minutes for questioning, and we'll follow up with questions later on. You can directly communicate with the appropriate person or via email. Again, thank you, Dr. Lee. The floor is yours. Welcome.
Thank you, Chairman Saitief. Do we have the slides by any chance? Perfect. So I have the privilege of sort of framing and kicking off this Budget Finance Committee presentation. I'll just keep moving for the sake of time. You see a picture here. This is actually the Treaty Oak. So we ran down a picture. So this is the Treaty Oak in Austin. That was the purpose of this slide. I still prefer that huge, beautiful, spreading heritage oak, but this is the Treaty Oak for Austin. And then I actually wanted to offer 2 framing thoughts before I hand over to Jeff and John. The first framing thought is to remind us that there are things that we have been able to move forward in the healthcare equity plan, and major things we've been able to respond to in direct response to the needs that were emerging from our patients and community, or the things that were clearly connected to work that we were doing. And the reason we were able to make that nimble response and accelerate the timeline on critical interdependent parts of this work is because we have wisely stewarded our strategic reserves, because we have a little extra altitude and the ability to maneuver as we move into this significant and complex space of building the health system that our community truly needs. So I have the privilege of sharing with you a story of the very first patient that we saw in our Bridge clinic. And this is one of those services that was not on the docket for several years, but we realized that it needed to be. So as Dr. Shalsha mentioned a little earlier this evening, those services initiated last week. And with permission, I have the privilege of sharing this write-up from Dr. Audrey Kwong, and again, with this patient's permission. So the very first patient that we saw was named Gigi. And actually, as I share this, I would invite us to imagine the alternative. What would have happened to Gigi had we not stood up respite services, transition to care services, and now Bridge services? So just hold that in your mind as we walk through Gigi's story. Gigi was our very first Bridge patient. She spent 3 weeks in the hospital, another 2 weeks in a nursing home before arriving at respite care. Her journey began when she was found unconscious and in shock, suffering from heart failure and kidney failure that required special blood pressure support medications and short-term dialysis. Once she arrived safely in respite, Gigi needed a lot of care coordination. Here's what that included. Pharmacy to get her a special blood thinner for a blood clot she had in her neck, cardiology for her heart failure, nephrology to support her kidney failure, psychiatry to address her bipolar disorder, and medication-assisted treatment for her long history of substance use disorder. Dr. Audrey Kwong took care of Gigi at the Bridge Clinic. Gigi was able to get her labs done on site, meet with a nutritionist, and request a women's health exam, something she hadn't had in over 20 years. The following week, Gigi returned to the Bridge Clinic with concerns about a possible urine infection. After sharing her issues with the respite team, she was seen at the clinic within an hour for an assessment and a urine test. Gigi shared with our team how grateful she is to be alive. She wants to work on improving her health and finally feels like she's in a safe place, both physically and emotionally, to get better. And this is an example of whole person care that we are moving nimbly. The individual care, but also the system of care and the ability to stand up this service because we have preserved the flexibility to maneuver through this uncertain space. This is why we do what we do. This is why the budget you're about to hear about matters. And I just wanted to provide that framing before handing over to my colleagues, Jeff and John. I guess I have one more slide. This is those 4 icons we saw earlier. So we're now in the right-hand column. We're going to articulate what the program priorities you heard about earlier mean in terms of numbers. Over to you, Jeff.
Thank you. So just a quick housekeeping matter. Again, just as a reminder to everyone, this is a proposed budget. I promise it will change. We're still working on things. There's some things in it that we haven't considered. There's some additional work that we need to do on our side. So a lot of discussions, and you'll see our calendar at the end of the presentation. A lot of discussions, but the main takeaway is this is proposed and nothing set in stone. To borrow a branch on the tree of truth, the truth tree, financial strength and flexibility, I think, is what we're delivering the proposed budget on. And, Dr. Shalsa made a comment in one of his presentations about doing all this and not causing a lot of financial worries. And, one of the things that to strongly consider is by having financial strength and flexibility, having a long-term plan, having strategic planning on what we're trying to achieve, especially in measured steps throughout the continuum of care, allow us to consider and do some of the things that we're doing. And there's been a lot of discussion tonight on all those things and much more to come. In addition, it provides the strength and the flexibility to take on and potentially mitigate some of the risk that Central Health faces. And I know that I've gone over this before, but I just would be remiss if I just don't mention that there are a lot of risks that we have as a healthcare organization, including regulatory risk, even potentially beginning in November. We don't know what that looks like. And then secondly, healthcare finance volatility. Things can change, and they can change quickly, and they can change substantially. Also, legislative risk, we know that exists. Unforeseen capital requirements, whether it's Central Health or one of our partners. And then the unknown, what we don't know, is always a potential. So, so with all that said, I think this budget delivers, it resonates with me related to the branch of financial strength and flexibility. So, kind of kicking off into the highlights related to reserves. So, one of the things that we did for our forecast is we went into fiscal year 2024 and we did estimates. Where are we going to end up on our spend? Where are we going to end up on our contingency reserve? And so based on that fiscal year 2024 estimate, we're estimating that our beginning balance in 2025 will be $494 million, which is higher than we anticipated in our budget. And a lot of that increase is related to, number one, significant increase in interest income just due to higher rates of interest that we've achieved on our investments. Secondly, just construction delays have resulted in delayed openings of some of our clinics, and there have just been some expenditure or budget to actual savings in that regard based on what we planned in our budget. So as a result of those higher than anticipated reserve balances, there are kind of two approaches that we're taking related to that. One is the acceleration of clinical services, and I think you heard a lot about that earlier, but there's a list of some of the services that are being accelerated from the health equity plan, the timing of those services. And then secondly, we had anticipated in past years doing a debt issuance for the remaining of our capital projects that are kind of, quote, on the books. Instead, you'll see a significant investment of cash financing. And so you might ask, well, why would we do cash? I think part of the simple answer is, A, we have the resources to do it, and B, we will achieve significant interest savings in the long term, just based on current market conditions. We've been really fortunate in the past where we've gone to market when market conditions were much more favorably, but just like we're earning higher interest on our cash balances, we would pay more in debt service. So what you'll see, just to put some numbers to it, over the next 2 years, we plan to cash finance $65 million in our capital budget. And based on that cash funding, we anticipate achieving interest savings of about $35 million to the taxpayers, based on cash financing rather than issuing debt. So we think that's a strategic way to use some of those reserve balances, provide more services, use the health equity plan as our North Star, and achieve significant savings in the long term to our taxpayers. And then the last note related to a highlight is just that we are proposing the budget at a tax rate of 6.5% over the no new revenue rate, which is what we said we would do in the financial forecast. And again, based on long-term planning, the tools that we use, again, we think that gets us to our targeted days of reserves on hand range at the end of our forecast period, which coincides with our health equity plan timeframe. Next slide. This slide is just a inception to date history of both the taxable assessed value in Travis County over the last 20 years, and then the red line is our tax rate from a historical standpoint, and you see to the right just a slight upward tick of the tax rate over time. Next slide. Excuse me. So this is a new slide. This is predicated off a request from Manager Jones. His request was, can you show us 5-year trends of major hospital districts based on the tax rates and the percentage of tax burden that each hospital district has in their taxing jurisdiction. And so I know there's a lot of information here, and it's I wouldn't try to follow each line on here, but what I would, the takeaway on these graphs is that when you look at the bundle of bars, and again, it's 5 years in each bar, you see a trend that you've seen over the past 5 years that we've presented this data, which is Central Health has the lowest tax rate of all the major hospital districts, and that's the graph on the left. And you see Central Health down at the bottom. You see the tax rates on the bottom legend. And then secondly, as it relates to the proportionate amount of hospital district tax to the overall taxing jurisdiction, the bottom legend represents the amount that each hospital district is as a percentage or as a proportion of the overall tax burden in these applicable counties. And again, Central Health, which is at the bottom, is anywhere between 4 and 4.5, almost 5%, which is significantly lower than all the other districts in this graph. Yeah, which is footnoted there on the left. But yes, from a different standpoint, absolutely.
And also, just I didn't ask this, but we maybe look at it later, is the population, income population of the county to look at.
Okay.
Because if you look at the 5 largest counties, the percentage of population of wealth, Travis County is one of the wealthiest ones. And so if you look at, my point is, if you look at that in comparison to what we're doing here, that tells us a story that we need to be mindful of it. Or is the burden in other counties greater than ours? And that's the question I'm trying to get at.
Got it. Yeah, I think we can get some data on that. But yeah, thanks. So yeah, we just we put this together just to show a little history, and we'll follow up with you on that. Next slide. So this slide is just the traditional, what's the impact to the average homestead value? And again, I think you saw in a previous presentation what the average homestead value is. We're showing 2 years. We're showing fiscal year 24, and then our proposed budget, which, by the way, I think we mentioned this, but I want to mention it again. These numbers will change because we have not received the certified roll. But based on our proposed budget and the information that we received from the appraisal district, you see the approved, the average taxable homestead value, our proposed tax rate, which is 10.4393 cents per $100, and then the tax bill based on that proposed rate and the average homestead value of $511, a little over $511, which is a $32 increase from the previous year average homestead and that tax rate. Next slide. So this is a graph of 3 years worth of other revenue. 3 categories: interest income, lease revenue, and tobacco settlement. Really the big takeaway on this slide is interest income has been substantial over the last couple of years. You see at the bottom of the graph, interest income is the blue area. You see that in fiscal year 22, we were under $5 million. And then as you work your way up the graph in fiscal year 23, it was substantially more. The middle bar is the fiscal year 24 year to date. So we haven't even gone through, this represents 7 months worth of interest income, and we're probably at about $17 or $18 million. You see the budget, which again, we budgeted substantially less than that. And then you see our preliminary budget, which we're proposing around $27 million. So we're taking into account market conditions and reflecting that in our FY25 budget, that will budget significantly more in interest income than we have in fiscal year 24. The other part of this is from a lease revenue standpoint. You know, there are a couple of components around lease revenue. There's the ground lease that we have for the 2 tracks on the downtown campus, the CEC building, and the hospital parking garage. The CEC building is being remitted back to Central Health as of September 30th, 2024. So we haven't budgeted for that additional lease revenue in fiscal year 25. Next slide. So this is a new graph also as we look at implementing our health equity plan, and as we look at investing in our direct healthcare services. Manager Motwani, you asked, or you made a comment earlier about, gosh, it'd be nice to see a graphic of kind of what we're doing, like in a graph as far as how we're expanding. This kind of correlates with that in some regard. You see the fiscal year 24 specialty areas, and then we have spaced them out by budget. And then you see FY 2025, the significant increase in both number of services and total investment in the direct healthcare services. And I think that's indicative of all the things that John and Alan and Dr. Lee have talked about related to our expansion of services and implementing those needed services. So we'll keep working on these type of graphics and hopefully bring some cost metrics into it that will be more meaningful. Next slide. So this is another slide that reflects the investment that Central Health is making, and it's kind of a historical graph of where we've been since October of 2021, both in number of full-time equivalents, or FTEs, which is the number up on top of each bar. And then the total, the bar actually represents a pay period spend in 6-month increments. So we picked a pay period in 6-month increments. And the intent of this graph is to look at both FTE growth and salary cost as it relates to growth, not only since October of 2021, but projecting that out in 2024 in our proposed budget in 2025. Significant growth. The 3 bars on the right represent projections, and the projections are related to filling up to 100% of our full-time FTEs in 2025, which you'll see here in a minute is 837 FTEs, which is a significant increase. The other takeaway on this is just John mentioned earlier this evening that we're building infrastructure. And you see the infrastructure that he's talking about in both the blue and the green areas, but then you see the red areas or the bronze areas starting to increase. That these increases represent our increased investment over time of our direct healthcare services. So you see exactly what's happening, which is we're building some of the infrastructure and support, and then we start building out our clinical direct services so that they're able to deliver and have the proper clinical support to deliver the healthcare. Next slide. So attachment A, which is our high-level budget, 3 columns. You see the fiscal year 24 approved budget. The middle column is the 2024 year-end estimate that I referred to, and then the right-hand column is the proposed budget. Again, the tax rate at 6.5% over the no new revenue rate, and then you see the total FTEs up there at the top. Kind of looking at the year-end estimate, again, at the bottom of it, you see an ending contingency reserve balance of $494 million, which is what we were talking about in the highlights. That rolls into 2025. And then you see the property tax amount, which again represents the rate and the increase I talked about, the interest income. And then on the expense side, you see healthcare delivery, which is a significant increase from our previous year's budget. And then on the transfers out, this is the part where we were talking about the cash funding the capital projects. So there are 2 elements in the $59.9 million amount. The first, the larger amount is the $50 million transfer to cash finance the kind of the large tranche of cash funding in fiscal year 2025, and then an additional $9.9 million transfer to our emergency reserve to maintain our 15% as dictated by financial policy. So you see overall a total spend of $470 million, total revenue of $386 million. That's almost an $85 million difference, and that difference would be made up in our emergency reserves. Next slide is just attachment B, and this is just more detail. I won't spend a lot of time on this, but I do want to point one thing out on inmate health. If you're looking at 2024 and 2025, you may ask yourself, gosh, it looks like there's less dollars in that line item. There really are probably more dollars for inmate health, but we're providing direct services by specialty lines, and those costs will be reflected down in the direct healthcare services. So the $1 million amount that we're budgeting for is primarily for some of the things that were mentioned earlier, which were pharmacy and case management related to these areas. Overall, our direct healthcare services budget is increasing from 29.2 million to almost 54 million, which is about an 84% increase between years. Next slide. And next slide is just the clinical support. Last is the support related to human resources, compliance. You know, we're starting to see patients now. There's a really big revenue cycle build related to providing care and developing a clinical practice, financial support, and then community outreach and education around our community. Next slide. So I think this slide was in our previous presentation, but again, this is our calendar. We have added a few meetings in August on the right, so we'll coordinate these related around our process of approving the proposed tax rate and then public hearing requirements. So you see that there are a couple of meetings back to back related to that process that may have been a little different on the other calendar. But still more opportunities to discuss our proposed FY 2025 budget. So I'm going to turn it over to Dr. Lee to close out our budget presentation, but I'd like to thank, prior to turning it over, thank all the finance staff and all of John's team. The whole organization has really stepped up and really accelerated our budget process to bring hopefully meaningful information to you guys to start discussing.
Thank you, Jeff and John. And let me begin by echoing that thank you. There are hundreds of people standing behind the work that we've presented tonight. We appreciate all of you. Thank you so much. This is clearly a lot. You all have commented on that, but I want to offer a couple closing thoughts. The first of which is that this is your vision. This is the healthcare equity plan that you envisioned and you boldly brought forward, and it has been our privilege to begin to turn that vision into reality. We are doing the work. By the time we close out the next fiscal year, the number of people in the organization will nearly have tripled from the day that I joined the organization. The volume of specialty care visits that we are providing directly in our care environment will have increased by an order of magnitude over this fiscal year. And along the way, we will be doing that work that I think your word, Manager Mawagi, is gutsy. I do think it's gutsy. We're going to be working to earn trust, understand, deliver whole person care, meet people where they are, make one size fit one, across the full range of what is needed to thrive in health and across the journey of a patient's care in all those chasms where we need rope bridges and safety nets under those rope bridges, and they have not been built. And so this is the time for focus. This is the time for us to deliver and keep our promises. This is the time for us to remember that we are strongest when we are one trunk, many branches. And those branches of the tree that you see here, we need to lean in to those branches to nourish the tree. I'll mention one in particular, which is our people and our culture. If we take care of the culture we have today, where this feels like the mission is alive and well and vibrant, and this is not a job for any of us. And while we are government and we have the financial strength and flexibility and accountability of government, the energy in the organization feels like a startup company. And if we can continue that beautiful and dynamic mix, then we can accomplish these goals. And so part of this request is to please support us in focusing. Please support us in taking care of our people. This is a pivotal time that will set the foundation for what's to come. This is a really important year to come. Thank you.
Thank you so much. I just feel like doing mic drop, literally. There's nothing more to say. Again, I appreciate you, commend you on all your efforts that you have done and continue to do. As a reminder to board members, this is not the last that we are going to be hearing from these amazing folks. So in light of the time, just wanted you all to be cognizant of it, the questions that you may have right now. Just realizing that we will have multiple opportunities to intervene and to provide our input to this important matter. And thank you truly for all you do. And as a board member, I can definitely attest that our heart is with our people and we want to serve them and as the best as we can, and everyone deserves patient-centered care that is really targeted toward those patients, and we meet them where they're at. Again, thank you for that. Members, does anyone have any burning question that they would like to ask now, or it could be help? Yes, Manager Valdez.
Yeah, yes, please feel free to reach out to Brianna and for any questions you might have.
Thank you so much. Manager Matwane?
I've never felt the need to applaud when I've seen a draft budget, but
That's literally why I said mic drop. Like there's no more to say. Thank you. Yeah, I can literally feel the effort, the love for our community in that. Thank you so much. So look forward to seeing you again soon, and feel free y'all to reach out to anyone if you have any questions. Thank you. And at this time, I am happy to confirm the next Budget and Finance Committee meeting date, time, and location. Managers, our next Central Health Budget and Finance Committee is tentatively scheduled for Wednesday, July 24th, 2024 at 4 p.m. at the Central Health Headquarters, 1111 East Cesar Chavez, Austin, Texas 78702. At this time, I'm ready to accept a motion for adjournment.
So moved.
We have a motion on the table and a second. All in favor of adjournment?
Aye.
Aye. We are adjourned. Thank you.
Okay, managers, we have one last meeting. It'll take about 15 minutes, I promise. We'll be very quick. So don't run out. Okay, today is June 12th and it is 8:30. As a quorum of the committee is in attendance, I'd like to call to order the meeting of the Central Health Executive Committee. And we'll proceed to the agenda. First, we need a motion to approve the minutes. A motion from Manager Musaitiv, a second from Manager Brinson. All in favor? Okay. Second item is in your backup, so we're not going to take it up, and that's the it's the scheduling of items in the future. I know Manager Motwani, you had an item you wanted to mention. Do you want to just send it to me, or do you want to mention it right now?
It's just a concept, and I'll mention it, and I'm sure staff will follow up, or you will. It's
Okay.
just if there would be some mechanism for us to hear how we may be looping back with folks who come to do public communication.
Okay.
I think sometimes it kind of warrants feedback. Obviously, in those moments, we're not posted for discussion. But on anything that may be of heavy material, it would be great to know how the organization is responding back.
Okay, if you could take that. Okay, all right. We'll move on to item number 3, which is discuss the 2024 Central Health Board of Managers Retreat. I just want to point out that there is a memo in your backup, and I want to point out 2 things about it. We're looking at a scheduled board retreat on October 23rd. The reason for that is pretty obvious, I think. We have a lot to get through before then, in terms of our budget. So that's the date we're looking at. We have on this memo a list of retreat topics, and these were gathered from the previous conversations that we had. So I know that two of our managers had two things they wanted to mention. So I'm going to take that right now, and then you can continue. I mean, we obviously have more time before we have to set the agenda for the retreat, so there'll be more opportunities. But at this time, Manager Jones, was there anything that you wanted to say right now about the retreat? And then I'll go to you.
Well, I was hoping we were able to have done it before the budget side, to be honest.
You were, okay, you were hoping what now?
We were able to have our retreat prior to this budget
Yeah,
cycle.
I understand that.
We've asked several times, but I understand time passes, so some of the items I wanted to have addressed during that budget cycle. Now, obviously, they won't happen in October. But I guess on the next item that we were talking about is the whole structure of how the district came about, where are we going, and that
Okay.
type of thing. I'll discuss in that section. But I
Okay.
would hope that we could have, at least going forth, one retreat a year, and that would be prior to the budget cycle as
Okay.
opposed to afterwards.
Okay, well, maybe we can, if there's some things in particular that you think are important for us to discuss before the budget, we can look at putting those on agenda between now and the
Okay, I'll
budget.
get with you. Sure.
Okay.
Thank you.
But then I hear your other things, the history and the structure, and also the need for that retreat prior to the budget every year. So,
Thank you.
Okay. Manager Valdez, did you want to say?
Echoing the same thing, I was hoping that we would have a retreat prior to the budget. So especially since that we may not all be on the same page with what things mean.
Okay.
And I think that it would be a good opportunity for us as board members to have a conversation about what something means to us.
Okay.
You know, what does equity mean? What does equitable mean?
Yeah.
You know, what are disparities? These kinds of things and how they impact our population, how we can better serve them. What is going to be our commitment to social determinants of health that are not medical? And how are we going to work with our partners to make sure that those things are covered and that they actually step up and comply with what their responsibilities should have been and not necessarily accomplished to their best abilities? Those are the kinds of conversations that
Okay.
I'd like for us to have.
All right, I'm hearing what you both are saying. We'll see if there's any of that we can add on any of the agendas between now and the budget. And then we'll take it into, we'll consider how we can schedule retreats in the future before the budget time period.
On July the 17th, I think we have a meeting.
Yeah, we
to
might
talk
have an
about-
opportunity at one of those
Yeah, I
things.
said if we could add it there if possible.
Okay,
One last thing. We keep talking about or putting on the agenda map expansion
I
from
know.
6 months to 12 months, and yet it's a red flag.
well, it deserves the time
Well,
for the conversation.
I understand that, but this is something we've been asking for
I know.
for a long time. Thank you.
I have noted that. Okay, so I'm going to move on to the last agenda item, which is the 20th anniversary event. That is also a memo in the background, in your backup. I want to tell you two things about it that you're going to be hearing more and we need your input on. There's a proposal for 3 awards, a community award, a health award, and a champion award. We need board participation in the selection for those awards. So we'll be sending out a proposed process for doing that and would like y'all's feedback. I'm working with Ted on what that might look like. We haven't figured out all the details yet, but the point is that the board needs to weigh in on the selection for those awards. Also then, if you have any other comments about what you see in the backup for, for the retreat, please feel free to share them. I'm sure that you could send them to, send them to Ted or send them to us. Okay, with that, I'm going to move on to the last, did you want to say something?
Just one comment on the retreat.
Yes.
We have the item, a bullet, how do other hospital districts operate? We had talked about the possibility of a series of public meetings or conversations over the next 6 months to a year to talk about how we existed, where we are now, where we're going. So somewhere in either the retreat or another time, we have time to focus on that.
Okay,
Because I think we need to use this 20th anniversary to reflect on our
To reflect
present,
on-
past, and future.
And if I could add to that, I think it's a good idea. I'd like to somehow get some information to us before the retreat about how these different systems work, so we can have an actual,
on what now?
on how these different hospital systems work, so we can have some
okay.
concrete,
Ahead of time, so you
effective
can,
discussion
Okay.
as to where we wish to go.
okay,
Thank you.
go ahead.
I concur with my members. I think there needs to be that discussion. There might be potential risks in our budget. So I think in light of that, we need to have a conversation. So
Okay,
that's all I can share.
okay, well, let's work on getting that on.
Okay, thank you.
All right, anything else? Can say no, okay. Going to the last item, the next regular executive committee meeting date, time, and location is tentatively scheduled for Wednesday, July 24th at 4 p.m. At this time, I'm ready to accept a motion for adjournment. Manager Musaitis, Manager Brinson, all in favor? Aye. Okay, we're adjourned, everybody.